you have any issues, chat with us here in Zoom, or live chat on our website, or call 973-415-5100. Thank you, and enjoy the webinar.
Hello, everyone, and welcome to our PAINWeek Premiere webinar. I am David Glick, and I will be your moderator for the day, and I'm joined today by two distinguished colleagues, Dr. Michael Clark and Dr. Jeffrey Gooden. While I miss being able to attain live PAINWeek and PAIN Weekend events, this is really the next best thing. So I encourage everybody to visit the painweek.org website for more information about other PAINWeek Premiere and other PAINWeek programs. I believe we have 6 or 7 more PAINWeek Premiere programs scheduled through mid-December. And also, if you did not attend the PAINWeek live virtual conference in September, the enduring content should be going live shortly as well. So there's plenty of content there. There's also other educational information opportunities available through the painweek.org website, which I encourage everyone to visit. Today's program is going to consist of 2 CE CME credit hours for the program. The CE is certified by Global Education Group. In order to receive your CE for this session, you'll receive an email, usually early in the week, whereby you have to complete the survey questions, and then you can download and save your CE certificate. Again, I encourage everyone to visit painweek.org for additional information about this and other PAINWeek educational opportunities. If you'd like to follow PAINWeek on Facebook, Twitter, or Instagram, please make sure to search PAINWeek, one word. We really do appreciate your continued support for that. Webinars such as this really do not occur without the support of the health sciences industry, and we have a sponsor for the day, which is Hitsumitsu America. So we want to thank them for their support that allows this program really to take place. The format of the day is, after our first speaker, we're going to follow up with the sponsor program from Hitsumitsu and Dr. Gooden, and then I'll present the last session of the day, and we will have a Q&A session after that. So make sure to type in your questions and/or hold your questions, and we'll be able to get to them in a discussion at the end of the program. So with that, I would like to welcome our first speaker for the day, Dr. Michael Clark. Dr. Clark is the chairman of Psychiatry and Behavioral Medicine at Innova Health Systems in Falls Church, Virginia, and a professor of psychiatry and behavioral health sciences at George Washington University School of Medicine and Health Sciences in Washington, D.C. His presentation is entitled Chronic Pain Assessment. With that, I'd like to welcome Dr. Clark.
Thanks very much, David, and welcome everybody. Appreciate your taking the time out of a busy day and a weekend to spend the day with us. I think you'll enjoy the afternoon, and I will kick us off with what we typically think of as a foundational lecture, which is really chronic pain assessment and how we go about looking at ways in which to begin the evaluation. So, I have nothing to disclose, and really what we want to think about here is how we can more objectively assess pain, but more important, how we can put it into a comprehensive framework of assessing the patient, following that patient over time, and designing and refining a treatment plan that individualizes the approach and optimizes outcome. We'll talk some about various support tools that are available and how to incorporate these into your practice in a feasible way. You all know that the problem of chronic pain is substantial in this country and across the globe. probably at least a third of the general population experience chronic pain symptoms. And this means that about 100 million people are suffering from this problem, more than heart disease, cancer, and diabetes combined. And typically, the life satisfaction or suffering that these patients experience is rated as more severe than these other conditions as well. Unfortunately, most people really are chronic. If you cross the door of a healthcare practitioner with the complaint of pain, you're likely to have that for more than 5 years. And there aren't very many chronic pain specialists that really have the availability and provide access to specialized care for the vast majority of our patients. As a result, it's not surprising that barely over a quarter of patients will describe their pain as being well controlled and satisfied with the treatment they're receiving. As you get older, the likelihood that you'll suffer from chronic pain increases. Over the age of 75, probably half of people are experiencing this problem, and unfortunately rate it as more severe than cohorts in younger age groups. As you might imagine, this is costing the healthcare system dramatic sums of money, as well as society in general, as folks with chronic pain retire earlier, work part-time instead of full-time, fail to be able to support their families, and even provide non-employed duties to their families. So we have to think about what not only is treatment that patients need access to, but how we would describe good treatment. As I mentioned earlier, these are folks that have a low quality of life. Unfortunately, the practitioners that are available to them are very heterogeneous in terms of their training, their scope of practice, and even their ability to achieve good outcomes. There is no standard definition of the multidisciplinary pain clinic, and many different disciplines can be or should be involved in the care of patients with chronic pain. There are evidence-based guidelines, and they emphasize interdisciplinary rehabilitation or other forms of integrated or collaborative treatment, but they too are small in number and difficult to access for a variety of reasons. It is these interdisciplinary pain programs that have the strongest evidence for achieving a good outcome because they have that comprehensive approach. They have the flexibility of designing and tailoring treatments, and they communicate with one another. Your challenge in the real world is trying to put these teams together in realistic ways that can simulate an interdisciplinary rehab center. This is really your best option for making sure that you have all the tools available and all of the expertise wrapped into the care of one patient. Now, we know that the average healthcare professional really doesn't receive much training in chronic pain and its management. Most primary care physicians describe that they don't feel comfortable treating pain, and they don't feel comfortable with the treatments that are often recommended. And even more so over these recent years, the problem with opioids has worsened, and that has removed a primary treatment that many folks were willing to engage in with appropriate mitigation and monitoring. And so now often feel as if their patients really do not have the full range of options that they feel comfortable prescribing. If you think about what it is that we're trying to take care of, it is hard to describe. Chronic pain It may be a symptom, it may be a disorder, it may be many different things. And it certainly impacts suffering, function. It has comorbid conditions such as depression, substance use disorders, not to mention a variety of other problems that occur. So the patient is experiencing an ever increasing burden over time. And we have to think about how to efficiently and thoroughly assess those problems, put them together in a formulation, and design and deliver that treatment plan. You can see here just a laundry list of problems that affect the patient with chronic pain and that are more than likely relevant to that patient's experience. The medical problems that that patient suffers from, the psychiatric comorbidities are substantial, but there's also the procedures that they have, the surgeries that they undergo. There are relationships to quality of sleep, their use of other substances like tobacco, and also just the challenges with setting appropriate goals and learning coping skills and thinking about how to integrate all of those modalities into the patient's life, because they're going to spend 24/7 with themselves. You're only going to be spending a certain limited amount of time with them, hoping to instill that plan and help them to be effective. The workup for a patient with chronic pain really follows the identical framework that you would follow for any patient. It is important to get a detailed history and to delve into the chief complaint and the history of present illness. It's important to get as many collateral sources of information as possible, to look at those medical records, hopefully primary source medical records, because with an overwhelming course and an overwhelming history, no patient can be expected to remember exactly what has happened to them and what their treatment has been or the results of tests. And there is often drift in terms of how that information is communicated and the etiologies that are described or thought to be in place. So you're hoping to really get back to the basics, to take that history, to examine those records, and then to actually examine the patient, which many folks forget to do because they see these patients as just an amorphous chronic pain problem, or maybe a chronic pain problem involving a site of the body, like the back or the hip. And the exam really does help you. It helps to define the effects of that condition, the manifestations of it in different systems, and to help detail the functional limitations that you're going to encounter in trying to rehabilitate the patient. Diagnostic studies are probably overly relied on and really should not substitute for these other components. Diagnostic studies should be used to rule in something that you are pretty confident exists and would like to verify, or if there's a condition that you really are seriously worried about and don't want to miss, you can use some of these studies to rule that out. As you think about formulating their clinical care, you really want to be postulating what the etiology of their pain is, understanding its various characteristics, and then thinking about the full range of consequences that their disorder is having on the rest of their life. There's obviously challenges. This is not an easily objectifiable symptom or set of conditions. It really does rely on your expertise and your ongoing interaction with the patient. And as you do things in their treatment, to follow up with them and see what has happened so that you begin to understand in real time what is going on with the patient, what works, what doesn't work, what makes it worse, what makes it better. That functional assessment becomes even more important when we don't have these objective ways to monitor chronic illnesses like diabetes or hypertension. So as you're thinking about your treatment and you're introducing and monitoring the patient with that treatment, it's important for there to be a conversation about what will you be able to do more of? How will your function improve? How will we define success? How will we know that things are working so that we should continue them, modify them, or just as important, discontinue them? The psychological assessment is important not only because of the comorbidities that exist in patients with chronic pain, like major depression or anxiety, but also just recognizing the stress, the life circumstances, the difficulties that patients are experiencing related to their illness. And because medications do play an important role in managing chronic pain, particularly neuropathic pain, it's important to know what medicines the patient has taken, in what doses, for how long, in what combinations, and to lay out basically a timeline and a grid to understand and perhaps decipher the types of medications or the pharmacologic actions that have worked benefit, those that have caused side effects, and that will help you think about what medicines you're going to be using in the future. So that initial hurdle is really how to talk to the patient and get that history. The patient self-report, unfortunately, is the gold standard because it is up to you to facilitate that conversation, to help the patient describe their experience, not to supply it for them, not to lead them down a path that perhaps will not be as effective for designing treatment, and to incorporate other sources of information, observing them, how they move, how they act, when they're engaged, when they're distracted, when they're being examined versus conversed with, to talk to other people that have similar interactions with the patients, perhaps more in-depth experience or understanding of them as a person, what they're able to do in different settings, and their perspective on why the patient may not be doing well. We don't have good physiologic measures in the chronic pain world to rely on. We can tell when the patient's distressed. We can look at the consequences of their illness and the management of it. But again, we don't have the objective measure to fall back on. It really is up to us and our expertise. And so to think about how you're going to structure your evaluation of the patient, people like mnemonics. They're catchy. They cover the information that you don't want to forget, but oftentimes it's hard to remember exactly what makes up the mnemonic. So better that you just learn the evaluation and that it becomes intuitive to your interaction with patients. But to get us started, the hamster mnemonic is the overall assessment. History, the assessment itself, thinking about mechanisms of pain, looking for social and psychological factors, designing the treatment, giving education about that, and then probably at least as important as the history, the reassessment, so that this is an iterative process, not one that you set and forget. There's a mnemonic for the history of present illness, LDoC-SARA. Again, this is the same history of present illness that you would pursue for any chief complaint. Its location, its duration, how did it come about? What characteristics or descriptors can you use that are more specific than just saying you're in pain or that you hurt. The severity and the goal for how pain is going to be defined as decreased to a level that's successful in the patient's mind. What makes the pain worse? What makes it better? And what other symptoms does the patient experience that they associate with their overall element of disorder? We talk about pain and measuring its intensity. You can see here a variety of simple scales that are incorporated into the patient's chart and their assessment process. There's no magic here. These are self-report. They are subject to interpretation. They are designed in a way to minimize that by anchoring the intensity scale with different words or numbers or faces. The most important thing to remember about them is that they facilitate your engagement and conversation with the patient. You are helping the patient to go beyond that initial description and begin thinking about their experience in more detailed ways that will be helpful to you. The psychological assessment begins with your first interaction with the patient. Part of the beauty of the psychological assessment is that there is a human element here, and how easily or difficult it is to engage the patient just in that relationship of being their healthcare professional will give you clues to how well they're coping, what psychological stresses they're under, and whether or not a psychiatric disorder might be present. That being said, it is an assessment unto itself, and it is important to think about whether or not the patient does have a comorbid major depression or generalized anxiety disorder. If a patient is suicidal and expresses that in any way, it is to be taken seriously. That is a red flag, and it is not a normal psychological experience for the patient in chronic pain. It is a sign of danger and needs to be investigated. Many of our patients who are suffering from poor coping and depression have histories of trauma and sexual abuse. Individuals who are misusing substances may have a history of addiction or may be involved in an active addiction that is compromising their outcome. And cognitive impairment can range from very obviously delirious or intoxicated to more subtle forms. Maybe because of all the medicine that the patient is on, maybe because of an early dementia that hasn't yet been realized, but should be thought about for the patient who's having trouble following instructions or whose outcome seems to always go off the rails in some way that's unanticipated. There are a variety of screening tools for virtually every diagnosis and every symptom and even every function. You can't incorporate all of these into your practice. The subject burden and the practice burdens are just too high. But think about what scales might be helpful to you, whether they're self-report or administered by a member of your team, and whether or not they need to be scored or simply reviewed. How you might use some over time to demonstrate to the patient progress or lack thereof. And remember that probably the most important comorbidity that you don't want to miss is a major depression. It will have an impact on the patient's response to treatment and their ultimate outcome. Making sure that you treat that condition to remission will improve your chances of a good outcome all the way around. One of the things that healthcare practitioners experience is the catastrophizing patient. You may not know the definition, but I'm sure that you know the patient and their response to stress. This is the person who magnifies the threat they're under, feels that the pain stimulus is dangerous, overwhelming, and that they're helpless in that context. Of course, there's a screening tool, but it's important to recognize that when you experience a catastrophizing patient, you can be guaranteed that they will not have a good outcome. At the same time, while there are formalized treatment programs that psychologists and therapists use to minimize catastrophizing, the everyday practitioner can do this. And it is most important to spend time with the patient, review the plan, and to educate them about their condition and how you're going to address it. Those simple techniques have been shown to decrease the amount of catastrophizing that patients exhibit. Another term that applies to these patients is kinesiophobia, which really is just the fear of movement. And for many musculoskeletal conditions, when patients try to move or do things, they oftentimes experience increased pain. This patient will interpret that as being a sign of damage or further injury or worsening of their condition. And as a result, avoid activity, withdraw from engagement, not do their physical therapy, and that will only worsen their condition. So they start down a vicious cycle. It's important for individuals to be worked with and desensitized to that fear and that avoidance, and to learn to tolerate those increases in pain and interpret them as signs of improvement rather than deterioration. As we think about giving patients medicines and reviewing the substances that they use in their daily life, the issue of chemical coping comes up. This is the use of a substance really that the patient has either learned or continues to seek as a means of mitigating the suffering that they're experiencing. It's in that gray zone between using medications for the appropriate reasons and frank addiction, where drug effect is being pursued. In this domain, patients are using opioids or other medications to feel better, to decrease their distress or anxiety, to help them sleep, to avoid conflicts, to minimize the use of other medicines. There is usually a strategy and a rationale that the patient has. It may not be very coherent or productive, but it is important to understand what it is that they think they're doing and what these medicines are doing to them. It's true that if patients are doing this, it's a poor prognosticator for how their treatment is going to proceed. And it's important to educate them and engage them and to consider whether or not this is progressing to a frank addiction and needs specialized care. As we think about whether or not somebody has a true substance use disorder, again, there are many screening tools, but the most important engagement is the conversation and the relationship with you. The simple cage questions for alcoholism can be generalized or modified for any substance, for any behavior actually that is unproductive and habitual for the patient. Have you ever felt you should cut down on your drinking or the use of a substance? Have people become annoyed with you, or are you annoyed with them for criticizing your use of a substance? Have you ever felt bad or guilty about your use of a substance? Have you ever had the substance first thing in the morning to steady yourself or to prepare yourself for the day or to get rid of hangover or other withdrawal symptoms? As you think about these questions, it really is, again, just a way to talk to the patient about what is your experience? What are you doing? Can you give me a better picture so that I can walk in your shoes and help you figure out a better strategy for how to do better in time? You can find all of these assessments online. There are many of them. The brief pain inventory is a form with visual analog scales and diagrams. It's easy for the patient to fill out. It's easy for you to collect and show them over time to help them think about their progress. But it really comes down to asking the patient about what you want to know. Patients will tell you almost anything if they feel safe, if they feel that it's non-judgmental, and if they feel that you're truly interested in them and using that information to help their treatment planning. You've heard me mention collateral information. It's important to use other sources of information to try to triangulate on getting the best history and formulation. We've talked about diagnostic tests and how they might be used. The more tests you do, the more likely you are to get an abnormal result. And if you are doing that without a rationale, you will then have to pursue further workups for that abnormality. And you will find yourself distracted and going down cul-de-sacs that the patient now latches onto, thinking we found a clue to what's causing my pain and you will be able to fix it. So better to start with the beginning, better to look at those old records, better to target and provide the patient a rationale for why you're doing a test versus not doing one, and then to stay engaged with them, trying other modalities of treatment, focusing on progress and positives so that the patient remains engaged with the primary treatment and not fantasies. As you develop that care plan, it is important to have a working diagnosis. You don't necessarily have to have the right diagnosis, but you should try to be as specific as possible. Try to stay away from global descriptive terms like chronic low back pain or chronic pain in general, chronic headaches. Think about the etiology. Think about what syndrome this is. Think about the underlying pathophysiology that you're trying to address, remedy, adapt, compensate for. That individualized treatment really should take into account all of the factors that are the history of present illness and the patient's experience. It may be that you will engage modalities as treatment in an incremental or stepwise fashion, trying to build on progress and to get incremental improvement. This will help you decide whether or not you should stick with a therapy or get rid of it and continue to build the plan in different ways. It may be that you need to and will try to engage a multidisciplinary team. Look for those other experts that can complement but not fragment your plan. Because if there are too many people involved and they're not coordinating or communicating, you will lose control over the management strategy. And as you think about what treatments you're going to use, there are always non-pharmacologic treatments to employ, whether they are based on your relationship and spending time with the patient, whether it's referring people to other types of formal therapy, or whether it's physical therapies that you want the patient to engage in addition to the medicines that you prescribe. And when you do prescribe those medicines, thinking about how they too can be rational in their combination and not just additive or multiplicative, ultimately winding up with polypharmacy that makes no sense. That risk of abusing medicines, misusing them, even diverting them, and ultimately dying from an overdose is important to pay attention to. It's gotten easier to do this as we have moved back from the prescribing of opioids and polypharmacy, such as the combination of opioids with benzodiazepines or other sedative hypnotic agents. But still, you should think about the risks that your patient will not be able to control their use of these substances and what to look for in terms of making the diagnosis of addiction. Again, a number of screening tools. They all cover the primary criteria of addiction, but they facilitate that conversation so that the patient knows that these are important elements of their care. And if they experience some of these symptoms or engage in some of these behaviors, that they feel comfortable sharing that with you because they know you have their best interests at heart, not just looking for a way to kick them out of the practice. The behaviors that patients engage in are infinite, and some are obviously more risky, some are more predictive of addiction. When patients are engaging like some of the behaviors that you see on this screen, obviously there is likely a problem, and you certainly need to investigate and confront these behaviors to understand why they are happening, to get them to stop. And if the patient needs help stopping them, that you can decide what kind of help you're going to provide them. So, in contrast, there are behaviors that are less predictive of addiction. And you should not jump to the conclusion that a patient has an addiction. You should help figure out what's going on. Why are they doing the behavior that they're engaging in? They may be hoarding medicine after you went on vacation and they ran out of medicine for a week and couldn't get anybody else to provide the prescriptions. They may be requesting specific drugs because they do remember their previous treatment and they know what worked and what didn't, and they can save you some time. They may be increasing their dose because they've learned that it waxes and wanes, or that certain behaviors or activities precipitate an exacerbation, and they're trying to head that off or deal with that and not bother you. So again, it's a relationship. It is a form of partnership. It's not an equal one because you are the expert and they are the ill patient, but it is a productive one when it works well. The reassessment is really the key to determining and reaching efficacy in your treatment. You must consistently reassess people. These are not patients to put off, to skip appointments, to let time go because you find them difficult to engage with. Upfront time is a good investment. It shortens the subsequent visits. It decreases the calls in the middle of the night or the trips to the emergency room. And that assessment really should assess the efficacy, the goals, the side effects, their quality of life and functioning, and what are the problems that they perceive to be having. What is it that they don't understand? What is it that you can reassure them about or educate them about or change because you now have new information? And remember to re-examine people, to try to find that consistent engagement with them, not only to strengthen the relationship and to reassure them that you know their body and the symptoms and the limitations that they're experiencing, but also to be able to document in your own mind improvements in function, in movement, in strength. That will go a long way to helping the patient. The 4A's, another mnemonic: the degree of analgesia, the severity of adverse side effects, the function or activities of daily living, and any aberrant behaviors, not just misuse of medications like opioids, but just non-adherence in general, doing exercises wrong or inappropriately, overdoing certain activities, hoping that you'll get stronger quicker. These are all aspects of, are you following the treatment plan? Are you engaging in a consistent treatment plan? And how do those modalities come together as a recipe? You want pain management to be individualized. You do that with a comprehensive evaluation and designing that treatment plan and changing it over time. You want to assess and treat disability and physical and psychosocial and psychological comorbidities. And again, you're trying to find the simplest approach to using combinations of therapy. You're not just adding on therapies and turning the patient into an onion of treatments. You're getting rid of things that are problematic or ineffectual. You're building on success, and you're constantly trying to achieve a better outcome for them. When to get expert consultation? Well, when you feel you need help. If you feel the patient is not doing well, if you're not certain of the diagnosis, if you need access to specialized expertise or the patient needs access to specialized treatments, if you just can't get to the outcome that you've been trying to get to and you can't figure out why, ask someone to help you. If you find yourself engaged in a treatment program that, whether it's opioids or other medications, other therapies, well, you're not sure. And so let someone else reassure you that it's okay, or it could be refined or changed. If there's any evidence of growing misuse or abuse, you think that an addiction is present, you will likely need an expert in addiction management. And if you've run out of ideas, you've tried different things, you can't think of anything new, ask a colleague, get a consultation. There are infinite numbers of strategies to pursue. So in conclusion, it is important to have a formalized and yet a stepwise approach to pain assessment and management, collecting information, putting that formulation together, utilizing tools that might be of help to you, but setting realistic and achievable goals for reductions in pain and increases in function. Think about the way in which you're going to manage these patients comprehensively. They will likely not respond to a one modality or a one algorithm approach. Minimize those specialist referrals, retain control and the coordination of the patient's care. Use those other forms of expertise when you really need them. So I will stop there and remind you that the next presentation is not certified for CME or CE credit. And I will see all of you again in the question and answer period. Thanks very much for listening and joining us today.
Thank you, Dr. Clark. I'd like to remind everyone as well, again, about the question and answer session that'll take place following the last session of the day, which would be mine. But I'd like to take the moment to introduce our next speaker, Dr. Jeffrey Guggen. Unfortunately, they didn't give me the script to introduce him, but technically he's a man that requires no introduction anyway, so we'll let him introduce himself. But I do have a funny story, if I can take a quick second. You're gonna love this. So I was sitting in on the PAINWeek PREMIERE session on Wednesday listening to your talk, thinking my shoulder is really hurting, and there was a Salonpas patch on the corner of my desk. So I put the patch on, and I credit that with helping me sleep a little bit better that night too, so I was pretty happy. But when I woke up in the morning, I decided to give it a test that I don't know if you have yet, which is called the shower test for adhesion. So I took a shower with the patch on. It stuck like glue, didn't peel off, and appeared pretty dry when I got out of the shower. So that was pretty impressive. So with that, Dr. Guggen, the program is yours.
Thank you, David, so much. And Michael, great talk as usual. Let me share my sound with you because we do have some video clips. Let me, okay, and let me try to share my slides. David, do you see my screen by any chance?
I do see your screen.
Great, thank you guys so much. So as Dr. Clark mentioned before, this particular presentation is through our sponsor, who is Hisamitsu. Many of you may or may not have heard about Hisamitsu. They're the maker of Salonpas. So this talk, although I'm going to try to keep it somewhat academic, is a promotional talk speaking about their particular line of products. But what I did do for the presentation is include many different options for topical analgesics, as well as the most recent guidelines for using topicals as first-line analgesic agents. All right, so I'll review with you the difference between systemics and topicals. That's kind of brief. The different classes of either over-the-counter or prescription agents. Talk to you about some of the newer guidelines that are out, and then review with you some evidence. Yes, there is indeed evidence for over-the-counter topical analgesics, and we'll do some polling in between to get your thoughts on those scientific messages. So just kind of to lay the foundation, you know, here in the US, we're different than many parts of the world who prefer topicals. But when you survey primary care docs and you survey consumers, if it's available, they prefer to take or recommend an over-the-counter medicine before using a prescription agent. And for some reason, over-the-counter medicines are generally thought of as safer with less efficacy. I'm going to kind of debate that with you in just a moment. To get us started, here's a television commercial. You might recognize Dr. Bob Arnott. He's a medical correspondent, and Bob did one for the over-the-counter lidocaine patch.
Dr. Bob, what should I take for back pain? Before you take anything, I recommend applying topical relievers first. Salonpas lidocaine patch blocks pain receptors for effective non-addictive relief. Salonpas lidocaine patch, roll-on, or cream.
All right, just to give you an idea of the line of products that Hisamitsu has, you could see here on the screen. There are 10 different products. 5 are counter-irritant, rubefacient-like products, which we'll talk about, that contain methyl salicylate, menthol, camphor, those type of ingredients. There's patches and sprays and gels. There's lidocaine products, which we're going to talk a fair amount about in this talk. And there's a pain relieving cream, there's a gel patch, there's a roll-on, and then there's 2 capsaicin-based products. But the core line of products for Hisamitsu, for Salonpas, are their lidocaine 4% patch, and Dr. Vic just mentioned the adhesion. I'm going to talk a bit about that in just a second. If you've ever used the Salonpas patch, you notice it's not like your Flector or your Lidoderm patches. These things are thin, they're pliable, they're stretchy, they adhere to the skin. They don't create the moon craters. They don't fall off the way the other patches do. There's a smaller size pain relieving patch that has camphor as well as menthol and methyl salicylate. And then there's the pain relieving patch large, which has methyl salicylate and menthol. I'm going to talk a little bit about each one of these. Just to put it into perspective, you all know that diclofenac gel recently got approval as an over-the-counter agent. It came as a surprise to me that many of these over-the-counter products have a label. We would expect that for Voltaren gel. It was a prescription drug, but I'll share with you some of the labels or some of the instructions that come along with the over-the-counter agents. And they're labeled for specific types of pain. And just so you know, I'm going to share with you the data. The pain relief patch large got FDA approval, not just for mild pain, but for mild to moderate pain. It's the only over-the-counter topical analgesic that has that designation. And it's indicated for not just arthritis, the way the gel of diclofenac is, but strains, sprains, backaches, bruises. And the lidocaine patch has a broad label for temporary relief of pain. So if we're looking at the label, just so you know, these things kind of have a broad label. All right, if you could take your mouse, and on your screen, we're going to do a polling question. I should have some music ready to go. In the last 30 days, what percentage of your recommendations for an analgesic were for an over-the-counter topical preparation? Choose 0 if you don't recommend topicals, and then up to 25, 50, 75, or 100. What percentage of your over-the-counter analgesic recommendations were for a topical agent? We should have results coming in now. All right, a couple said they don't recommend, and then a third of you say up to 25% of the time, and then the smattering spread across the remainder. So that's good. Let's go and talk about the case for first-line use of topical analgesics. Now, I mentioned before that we're a little bit different than the rest of the world. Here's some data to support that. overseas, like in many Asian and African countries, topical analgesics make up almost half of all pain medicines, whereas in this country, it's about 18%. So we have to think, is the rest of the world wrong? Do we need a change in our treatment paradigm? Maybe it would be great if we had some data to support these topicals, and I'm going to share that with you in just a moment. But as a baseline, let's all agree that systemic analgesics get distributed widely throughout the body, even to parts of the body you don't want them to go to. So let's grab your mouse again, and here's a question. Overall, how concerned are you about adverse effects from systemic analgesics? Think about all classes: opioids, NSAIDs, gabapentinoids, tricyclics. How concerned are you about AEs? Not at all, a little, somewhat concerned, or very concerned. Got a little Saturday dance music going. All right, we should have our answers coming in. And if you see, the overweight is down towards the bottom. Somewhat concerned and very concerned make up 90% of the responses. And I would agree, right? We don't have systemic analgesics that don't have adverse effects. So let's go over those briefly. You all know the risks of NSAIDs: GI, cardiovascular, renal, platelet dysfunction. You know there's a population of patients that might be prone to those adverse events. Acetaminophen, 500 deaths per year doesn't sound like a lot, but 56,000 ER visits. It has a very narrow therapeutic index, so 50% of the overdoses are unintentional. Hey, I'm taking a cold medicine, I'm taking a headache medicine, I'm taking my hydrocodone with acetaminophen, etc. And I don't think we need to talk about opioid-related deaths. If you've seen the news lately, the overdose rates are on the rise again. We think COVID and the stressors have a whole lot to do with that. And clearly, gabapentinoids and tricyclics and baclofen and all the adjuvant agents have a myriad of adverse effects. The benefits of topical analgesics is it's targeted therapy. It's targeted to specific tissue sites out in the periphery. And here's a question I get all the time. What's the difference between topical and transdermal? Well, transdermal brings to mind transdermal fentanyl, transdermal clonidine, transdermal nicotine. Those medicines get throughout the entire circulation. They're meant to go deep through the tissues and be absorbed. Topical analgesics aren't meant to get absorbed systemically, even though they do to a small extent. They're designed to just target those peripheral tissues. Here are some examples: lidocaine, capsaicin, morphine, NSAIDs, nitrates, cannabinoids, of various agents that we'll talk about in just a moment that can penetrate through the outer layers of the skin to the stratum corneum and even get down to soft tissues and nociceptors. But again, our goal with many of these topicals is to keep them out of the bloodstream. Some of the purported benefits to topicals: clearly you don't need to swallow. There's less or no nausea and vomiting, no GI absorption issues. You can eliminate the first pass hepatic effect, right? This is a parenteral delivery system. You minimize plasma concentrations and hopefully minimize AEs. And one of the more exciting things, which I'll share some evidence for in just a moment, is we could spare the use of other therapies, spare opioids, spare NSAIDs, spare the adjuvants. And some patients actually appreciate this delivery system, and it might improve their compliance and or quality of life. You see here a list, some of those that I ran through already. I just want to call out one, which is very common in over-the-counter agents. It's called methyl salicylate. You know that salicylates come from acetyl salicylic acid. It's breakdown of aspirin and cause an anti-inflammatory effect. We have evidence that methyl salicylate works both as a counter irritant and also as an anti-inflammatory agent. And you see here other agents in the list that some of these we'll go over as well. So salicylates are NSAIDs with an anti-inflammatory benefit. And we know capsaicin is not just available in the 8% patch, but also in lower over-the-counter strengths. So let's talk about capsaicin. Hisamitsu has two different capsaicin products. They both have the same amount of capsaicin, 0.025%. which kind of suggests something to us. Look how low that concentration is. If you put these on, they feel hot. Why do they feel hot? Well, they activate a thermal sensitive receptor in our body from a family of receptors called TRP, transient receptor potential receptors. It happens to activate this vanilloid type 1 receptor. So when we talk about capsaicin, we say that it targets the TRPV1 receptor. Now we know from thousands of studies and from like knockout studies in mice that the TRPV1 receptor is an important analgesic target. And what happens is at first you deplete your pain chemicals, and then slowly it denervates, it kills the little epidermal sensory fibers in a highly selective manner, just the sensory fibers, giving long-lasting pain relief till those fibers grow back. Here's a picture of that. We've all seen something like this in our travels, where on the right side is a control, lots of epidermal nerve fibers in the subcutaneous space, and here is following capsaicin. 1 week later, you don't see the same density of epidermal nerve fibers. We know that 8% patch got approved to treat post-herpetic neuralgia. I've done quite a few of them in my practice. They recently, a few months back, got approval for painful diabetic neuropathy of the feet. Some of the overseas studies that overseas, they use this for all different kinds of neuropathic pain. Some of the overseas data supported the use in diabetic neuropathy, and now the label has been expanded. And I listened to Dr. Argoff's talk the other day, where I think it was Dr. Argoff who said, you know, there's some evidence now that this might work better on the second or third application than it does on the first application. Who knows if there's some cumulative benefit to it. So approved for PHN and now diabetic neuropathy. All right, let's go on from capsaicin and talk about topical local anesthetics. This is probably the most common thing that I've used in my practice is lidocaine topically. I published a few recent articles about how adhesion is very important, how there's a difference in the formulations. It's available in a lot of different formulations: sprays, creams, gels, patches. You know, overseas, they call patches plasters. You've all heard of Emla cream before, which is a mixture. Just so everybody's clear, there is what we call a monograph strength or an over-the-counter strength lidocaine. It's available up to 4%. Many of these products don't publish their PK data. So everybody always asks me, hey, can I use the 4% instead of the 5%? Well, I have to all the time because managed care doesn't let me prescribe the 5% for anything other than PHN. But we don't really know what the pharmacokinetics of one versus the other looks like. These have been shown to be relatively safe, even applying 3 patches simultaneously, 12 hours at a time. The plasma concentrations are 20 times lower than what we see with lidocaine toxicity. There are newer patch formulations available that you all know about. There's a 1.8% patch, which showed bioequivalence to the 5% patch. Lidocaine patch is listed in multiple neuropathic pain guidelines, including international guidelines. But remember, when you can't get the 5%, the 4% is available over the counter. Just to give you an idea, it's $1.65 a patch compared to over $8 for branded Lidoderm and almost $3 for the generics. And any of you that have used the generics like the Watson or the Mylan patch, the adhesion is clearly not like the branded or like the over-the-counter products. So these patches fall off and patients have to tape them or wear a sleeve. The Salonpas 4% lidocaine patch was the #1 selling lidocaine patch before 2020. But even though it was the #1 selling, they went back to the drawing board. They redesigned it, and it's now stretchy in all directions, better adhesion, and almost like what David talked about with the Salonpas menthol patch, methyl salicylate. This one is really, I've worn them before, a nice patch. The corners stay down, it doesn't bubble up, it sticks really nice. And what they've done now is they've now started marketing these to hospitals because, I mean, hospitals are paying almost $9 for a branded patch and almost $3 for a generic patch. They could save, you know, a lot of money by going to over the counter. So they have NDC barcodes if your hospitals are interested in this type of lidocaine patch. All right, worldwide, I think topical NSAIDs are probably the most commonly administered topical agent. We know that there are different formulations or different categories or classes of NSAIDs. So similar to tricyclics and opioids and any other class of drugs, if one class doesn't work for a patient, I was taught to try another class. So if you use a propionic acid and they don't get an effect, maybe try an oxycam or an indoline, or so just to keep in mind. And I mentioned before acetylsalicylic acid, methyl salicylate is the ingredient in many of these topical products, is hydrolyzed to the same salicylic acid. It's believed that there's multiple mechanisms of action because it's not just the methyl salicylate for an anti-inflammatory effect. Methyl salicylate is also a counter irritant, as is menthol. Menthol is actually a drug. I'm going to talk to you about it in just a moment. Not only does it have a cooling effect, it affects our peripheral analgesic pathways. Let's talk about topical diclofenac. I think worldwide diclofenac may be, there's billions of doses that have been administered, maybe the most common specific NSAID used topically. Here's how the topical diclofenac products compare to the tablet. You see the tablet in the top line. There's a Voltaren gel, which is now over the counter. Many of us historically have had to prescribe the Solaraze, the 3% gel, because it was generic and we couldn't get approval for the 1%. We know there's a Flexor patch, 1.3%. If you've used that, there's significant issues with adhesion there. And there's also PenSed topical solution, which is just this wet, droppy solution that you literally drop on your skin and you have to rub in, and it drains down your leg. So it works. It's just not the simplest or most convenient formulation. We mentioned that Voltaren gel has now gone over the counter, but I want to tell you a few things. If you look at the Voltaren gel label, it is not for immediate relief the way the Salonpas products are. The label says it might take up to 7 days to work, and it is only labeled for OA. If you look on the left-hand side, these were the studies, the phase 3 studies that got the drug FDA approved. One study, 12 weeks in OA of the knee, where they used WOMAC pain scores, and one study of OA of the hand, where they looked at pain intensity at week 4, pain intensity at week 6. All of these use the 0 to 100 NRS pain scale. And just so you see, here's the difference: 7 points, 7 points, and 7 points on the 0 to 100 scale. So oftentimes we need to really think about, these numbers may be statistically significant, but is there clinical significance to this? And many patients get relief from Voltaren gel. So I don't want to take anything away from it, but I think you should know that not only does this require the dosing card, so they have to spread out the goop on the dosing card, but they literally need to rub this in, wash their hands, or some process that goes along with using Voltaren gel, and it might take up to a week to work. Nevertheless, topical NSAIDs like diclofenac are recommended around the world in OA guidelines. Even our own American College of Rheumatology, the orthopedic societies recommend topical agents. But the most exciting thing is not just for OA, but now for musculoskeletal pain. Many of you have seen this at this point. Just a few months ago in August, the American College of Physicians and the American Academy of Family Physicians came out with a guideline following an extensive meta-analysis, which I'll show you in just a moment. And they said that topical analgesics should be first-line treatment for acute pain for musculoskeletal injuries that are not low back pain. And the reason they said that are not low back pain is because there's already a low back pain guideline. The second-line agent should be an NSAID. So here's their recommendations. They recommend clinicians treat patients with acute pain from non-low back musculoskeletal injuries with topical NSAIDs with or without menthol gel as first-line therapy. First line, not concomitant therapy, not alternative first-line therapy, not try something else and then try this. Your first agent should be a topical preparation with or without menthol gel. They look not only at pain, but also at physical function, symptom relief, treatment satisfaction, and AEs. The included trials in the meta-analysis were nearly 33,000 patients. And look at the next bullet, almost hard to believe, a systematic review with more than 13 million participants. So very large data review. So topical NSAID with or without menthol, first thing. Oral NSAIDs, oral acetaminophen, maybe second thing. Acupuncture, TENS, other complementary modalities, third. And they suggest not using opioids at all, including tramadol. Now, that was with lower levels of evidence, but that was their recommendation. They said that topical NSAIDs were the only intervention that improved all of those outcomes above that I listed in these patients with musculoskeletal pain. So just something to keep in mind. So why are we going to talk about Salonpas? Why are we going to talk about rubefactins and counter-irritants? Because the Salonpas line of pain products contains menthol. The recommendation to use topical analgesics with or without menthol, and methyl salicylate, which turns into an NSAID. So you're going to hear these terms, counter-irritants, a substance that creates irritation or mild inflammation, like capsaicin or camphor or methyl salicylate. Capsaicin is also a rubefactin. It produces redness of the skin. It dilates the local circulation, and you feel heat from it. Just to show you how many products contain menthol, these are many of the over-the-counter preparations that we're familiar with. Most of them contain menthol. Many of the Salonpas products contain methyl salicylate, and some contain camphor as well. Now, I told you before that we're going to talk about menthol. Many of you know Dr. Bob Raffa, Joe Pergolesi. This is an article which I found recently is extremely enlightening. It turns out that menthol, I thought menthol was this funny smelling stuff that was in my, my dad's Ben Gay or Tiger Bomb. But it turns out that menthol also activates that thermosensitive receptor called TRP that I mentioned before, but it's not the vanilloid channel, it's the melastatin channel. Now, you don't need to remember that, but it turns out that they actually call the TRPM8 receptor the menthol receptor. And it acts as a counter-irritant by stimulating the nociceptors. That's the cooling effect that you feel from menthol. But then, similar to like capsaicin as a second benefit, this desensitizes the nociceptors by blocking the signal at the cutaneous nerves. I never knew menthol was a drug like that. That's kind of cool, right? And Dr. Pergolesi and Raffa said, look, this might not just be a peripheral anti-inflammatory blocker. This may actually work on central analgesic pathways as well. So I think we need some more data, but this was a pleasant surprise to me. There was a Cochrane review about 6 years ago that basically said, look, there's not enough evidence here to support the use of these things, although they do look pretty safe and well tolerated. Well, now there's more evidence. I'll share some with you, and I think this review needs to be redone. So grab your mouse. Just a quick question. In your experience, have these kind of agents, menthol, methyl salicylate, camphor, have these rubefactins with menthol been proven enough to be strong enough to treat moderate pain? Not just mild pain, but moderate pain. What do you think? Nothing like Saturday music to keep us going. All right, so yes, 18%, no, a quarter of you, maybe somewhere in the middle. What's rubefactin? 15%. I put that in as a joke, but still some of you didn't understand what a rubefactin is. So we'll cover it a little bit more, but for the skeptics out there, let me see if I can't convince you with some data. By the way, I was a skeptic as well until we did one of these studies that I'm about to share with you. So we do have evidence for these things. All right. Now, before somebody says, well, look, this wasn't a double-blinded, randomized, placebo-controlled, multi-center, or parallel arm, we would all love to see a state-of-the-art $40 or $50 million study with an over-the-counter product, but let's face it, that's probably not happening. So we said, what could we do to come up with some data to either support or not refute the claims of these over-the-counter agents? So here's what we did. We took a treatment group, 150 some odd patients, and gave them patches for 14 days. They had either arthritic, neurological, or musculoskeletal pain. We took a control group that didn't get the patch. And then just to kind of add a little bit of, sauce on top, we said, why don't we cross over some of the control patients for another 2 weeks and make them into treatment patients just to see, did their pain change from control to treatment group? We used a brief pain inventory, and that could look at both pain severity and pain interference as a measure of function. And we looked at side effects and satisfaction and how much did they, if at all, change their use of pills, of oral medicines. And here's what we found. After 2 weeks, the treatment group pain severity score dropped by 50%. The pain interference score dropped by 58%, right? Cut in half. When you looked at the control group, it was about 12 and 15%, right? Pain interference, pain and pain interference. So there was what looked to be a significant difference in their pain scores and in their functionality. In the study, in the treatment group, if you got a real patch, they said they used their oral pain medications a lot less, and 89% of them said we used it either less or a lot less. Almost 90% of people that got the patch in the control group used less or a lot less oral pain pills, and 90% plus were either very or extremely satisfied with the patch. So we thought that this was a good exploratory analysis to see what is the effect of these over-the-counter patches. So to us, the results support that this particular pain relieving patch, this is the Salonpas pain relieving patch, should be a first-line treatment and considered as part of your multimodal treatment regimens. The guidelines should look and consider these things as part of the guideline. This is out of a advertising piece from Hisamitsu, but you see here, look at the cost of this patch, 16 cents. What could you buy for 16 cents in medicine? Not a whole lot. The guidelines are recommending these as first line, topical analgesics with or without menthol. Why not try these things for your patients? We showed with data that it improved pain and it improved function. This is also out of one of the journal ads, 50% reduction in pain severity, better quality of life. Here's all of those domains of the BPI functionality. All right, you want more data? Here's some more data for you. This is the Salonpas Pain Relief Patch Large. This has just menthol and methyl salicylate in it. This is a bit of an older study done by a researcher named Higashi. Higashi said, you know what, we are going to do a randomized double-blind parallel group placebo-controlled multi-center study, and we're going to use a vehicle or a placebo patch, right? That's the placebo part. 200 patients randomly assigned to either got a real patch or a placebo patch to their area of pain. They measured pain intensity at rest and with movement for 12 hours after patch application, but the primary endpoint was the pain intensity difference, the sum of the pain intensity difference, the SPID, through 8 hours with movement. And they also looked at AEs and safety and some secondary endpoints. And by the way, we haven't talked a whole lot about this, but I haven't talked about it for a reason. The adverse effects associated with topical agents are minimal, especially compared to oral analgesics. And the most common ones, what do you think? Adverse skin reactions. There's very little systemic absorption of these medicines, and therefore we get less side effects. There are still side effects, but we think they're less. And what Higashi concluded was that this single 8-hour patch application resulted in significant relief of pain for those with mild to moderate muscle strain compared to the patients that got placebo. By the way, I mentioned before that over-the-counter products have a label. The FDA has approved this product. It went through the new drug application NDA process, and they got approval for mild to moderate pain. That's the date I said before, that this is the only product that actually has FDA approval to treat mild to moderate kinds of pain. All right, speaking of which, grab your mouse if you could, and let's do another quick question. How important is it to you that an over-the-counter patch has FDA approval to treat mild to moderate pain? How important is it to you that the patch has FDA approval to treat mild to moderate pain? Very important, somewhat important, or not important? On your keypads. All right, let's see our response. Very important, more than half of you. Not important to about 10%. Somewhat important, 35%. Good. That looks like we're moving in the right direction. All right. This, you saw most of the data already, but I put this in. It's part of their marketing materials. This is what the box looks like. It's over the counter. This is the large version. You see how it covers across the back, versus the version we used in our study is a smaller version, can go on joints, or you can put on multiple patches. Look at the cost of this patch, $1.66 a patch. And by the way, you can get coupons and samples and things of the sort. All right. I want you to think about these three buckets: over-the-counter pain treatments, treatments that have been reviewed by the FDA new drug application process, and treatments that are indicated not just for mild, but for mild and moderate pain. Salonpas really isn't a class by itself. It meets all these three buckets, and you see most of the other icy hots and aspirin cream and Voltaren arthritis meets one or two, but certainly not all three. You may see this in a journal ad. Not all topical pain relievers are created equal. You know about Voltaren gel. You may not, until now, have known about the data behind the Salonpas pain relief patch. When you compare the two, I've said this already, Salonpas starts working within an hour. That Higashi study, meaningful relief on day one, labeled to treat moderate musculoskeletal and arthritic pain, and the patch works locally, targeted for up to 12 hours. Whereas when you look at the Voltaren label, it might take up to 7 days to work. It's only indicated for arthritis. It hasn't been shown in strains, sprains, bruises, other ailments, not for immediate relief. And remember, to apply it, it requires that dosing card. If you have your smartphone available, you may want to take a picture of this link or write it down, us.hisamitsu, it's HISAMITSU/Salonpas-samples. You can get complimentary samples for your practice, for yourself if you have pain, your friends or family members, as well as coupons for patients to buy these at a discount over the counter. Remember before I said these are drugs. They're not without side effects. We just think that there are less side effects. But the same warning goes for topical analgesics as you would think for any other topical. You can't apply external heat to these things. You shouldn't put it over an area of open, abraded, or otherwise damaged skin. All of the warnings that you would use for any other topical. And look, if somebody has, the worst bleeding disorder, they're about to be in renal failure, if they have an active peptic ulcer, yeah, this is methyl salicylate. Although the plasma levels are extremely low of salicylic acid, you may want to exert caution when using these in the higher risk patients. So I think we're going to give Dr. Glick and Dr. Clark back some time for Q&A. We'll take some time for Q&A in just a moment. But I want to remind you, as of a few months ago, we have a national practice guideline supported by two associations, American College of Physicians and the American Academy of Family Physicians, that say when they looked at the data from thousands and thousands and thousands of patients with musculoskeletal pain, only one class of analgesic stood out as being most effective and safe, and that was topical analgesics with or without menthol. First line topical agents. Now, like all other therapies, certain patients are going to respond and certain patients are not going to respond. The only way to know, like any of our other modalities, is to try it. There are potential sparing effects of opioids, NSAIDs, acetaminophen, etc. The adverse effect profile in the studies we showed here was comparable to placebo. That's the kind of AE profile that I like. And not all over-the-counter products are created equal, right? Two of the ones I showed you here today have data supporting them. Some could actually get an FDA approval through a new drug application pathway. That was news to me. So I shared some of that with you today. But when you go back to your practices, I'd like you to think about the guidelines that are out recommending topicals as first-line agents, and think about the Hisamitsu line of products, the Salonpas patches, the lidocaine patches, the topical gels and creams, and even capsaicin for those difficult to treat pain syndromes. Here's the TV commercial that I did.
As a doctor, I agree with CDC guidance. I recommend topical pain relievers first, like Salonpas Patch Large. It's powerful, FDA approved to relieve moderate pain, yet not addictive, and gentle on the body. Salonpas, it's good medicine.
All right, on your computers with your mouse, if you could, over the next 30 days, what percentage of your recommendations for over-the-counter products will be for a topical agent? Just for your recommendations for over-the-counter products, what percentage will be a topical analgesic? Some answers. Hey, look at that. More than half of you said greater than 50%. That's great. Still some of you in the lower buckets that don't recommend topicals, but you really should reevaluate the data. And now that there are guidelines out, maybe think about changing that style of practice. So that's good. And thank you guys for your attention and for your feedback. Before we turn it over, I think we have a couple of minutes for questions. I'm going to stop sharing and see if there's anything that came in the chat box. All right. Can we get a copy of Dr. Gooden's slides? I don't think they're giving these out. I'll let David or Patrick take that one. I don't think they're giving those promotional slides out. There's something on cannabis. Recently was a recall on Salonpas patches related to the amount of methyl salicylate. Can I comment on it? I cannot. I don't know anything about it. I would Google it the same way that that you could. I don't work for Hisamitsu. This is strictly they sponsored this talk through PAINWeek. Can you comment on pharmacies sending faxes asking for signatures of various topical pain formulations? Lawrence, that's news to me. I think when we order compounding agents, they want signatures on them for their records, unless of course you're putting any type of controlled substance in there. I've never seen any pharmacy, especially these are over-the-counter products, ask for a clinician prescription. As a matter of fact, it's the pharmacists often that are recommending these, in the pharmacy themselves as an over-the-counter product. No other questions there. David, I think I'll turn it over to you, and feel free to type in any other questions if things pop up during the next session.
There's a really cool benefit to being the moderator. I get to ask a question and I don't have to type it out. Because I think this is a really important concept that I try and get patients to understand as well, because a lot of times you see that difference in understanding between, well, the over-the-counter might not be as clinically beneficial as, let's say, the prescription strength. But the problem that you run into, as you sort of commented on the generic lidoderm, lidocaine patches with poor adhesion, putting tape or something to hold them in place misses the point, because once it loses contact or adherence with the skin, you lose the ability of transporting the medication. So in a sense, the Salonpas 4% patch because it adheres to the skin so well, ends up with a higher bioavailability of the lidocaine. You actually get a better response.
So, David, it's funny you bring that up. I've recommended to a few of these companies already that they study pharmacokinetics, but I don't think it's in their best interest. And they're already successful over-the-counter products. But you know that we have a lower strength lidocaine patch, 1.8%, that showed bioequivalence to the 5%. So
Because
really, so it really would be great. And if I had to venture a guess, I would say you'd see variable pharmacokinetics across the board, that perhaps some of the over-the-counters are as strong as some of the less effective prescription ones, the ones that don't stick. So good point.
Great. Thank you very much for the discussion. I truly appreciate it. And
thanks,
all of you did as well. And I think one of the most common questions that I'm seeing here is, because I saw that in the last session too, is asking for the Salon Pas slide deck. So maybe some kind of informational brochure that can be emailed out would be a benefit, something for you maybe to bring back to the powers that be.
Dave, I will say that there were references on the study slides. If anybody wants those references, by all means, right? Or if you search my name or the Higashi name, but in preparing for this, if you search on menthol and methyl salicylate, you'll find no shortage of articles supporting their benefit. But remember, this is not a miracle cure, right? This is a first-line treatment. Might not be your final line treatment. And what better from a polypharmacy standpoint to mix in with your other medicines than one that doesn't have too many side effects? So I'm becoming more of a fan of these topical agents.
Yeah, I've been using topicals in our practice, armamentarium, since probably the early 90s, when everything used to have to be compounded. So yeah. I've been following the evolution along the whole course, and I've always been a fan and really appreciate it.
That's
so with
awesome.
That, thank you again, and look forward to seeing you on the next little occasion.
Thanks, David.
All right, so I believe that means I'm up again. So hopefully all of you can see my screen, and we'll move on to the last session of the day. I want to remind you that Dr. Clark and I will be available for a question and answer session at the conclusion of this slide deck and session. All right, so what I have for you today is basically a presentation on neck and upper extremity pain syndromes. It is not meant to be a full-blown, all-inclusive explanation of how to evaluate and treat neck and upper extremity pain syndromes. More so, it is meant to just kind of make you think in a slightly different manner, because the whole goal here is to give you little bits of information that can help your thought process that might get altered in a slight manner that we can then use to change the way we look at a patient. And that's our goal. So let's see if we can make that happen. I have nothing to disclose as far as conflicts. Our goals for the day are we need to be able to identify some of the primary and secondary pain generators that contribute to neck and upper extremity pain. I mean, that goes without saying. But I also want to talk about how we could have a problem with deficient clinical examinations. And this is one of the things that we touched upon in Dr. Clark's talk as well, when it comes to diagnosing these pathologies or any musculoskeletal pain, really. And then I want to also give some discussion points and consideration of how overlapping pathologies can complicate matters as well. So we start by talking about the misconceptions that we have with all pain in general, but let's talk about neck pain now, because neck pain really itself is not a pathology, it is merely a symptom. And when you ask people about what you think causes neck pain or back pain, you always get these responses like disc herniations and pinched nerves. Well, it's really not all about that, because there are plenty of other things that can cause pain. And the reality is there's no single fix for this because it's such a broad topic. There's so many different underlying pathologies in different places or regions where that pain or pathology can exist. And then there's variations of the type of pathology, even if it's at a single location. Plus, we all have different disciplines and we look at the patients from different perspectives. So there are sometimes, the proverbial many ways to skin a cat as well. And I think what makes me interesting as a physician, because I've looked at nothing but train wrecks for 30 years, so I get the difficult, chronic, or complicated patients, is that I don't consider myself any better a clinician than anybody else, but I just like to hang my hat on the, what I like to call the triage side of it. So even if it's a treatment that I don't do, I have a good enough understanding and experience with that treatment so that I can identify what patient may need that treatment or benefit by it in a highly patient-centered manner. So I kind of just a triager, really, when it comes down to it. My controversial statement that I always make, but if you understand the way that I look at patients, it makes sense, which is that chronic pain often occurs from a failure to adequately differentially diagnose and treat that patient. I mean, I ran into a waitress in a restaurant last night who's been treated for back pain for 4 months and has undergone a variety of different treatments, none of which have worked. And all I did was casually get involved in it, sort of on the side, made a phone call to her physician and changed the treatment that she was getting. And all of a sudden now we have a difference in outcome. So sometimes all you need to do is just step back and reevaluate. I use this children's toy as an example because we're all highly skilled, well-rounded physicians and clinicians, but we don't treat every patient. We have some patients that are square, some patients that are trapezoid, and we have clinicians that are square and trapezoid and cylindrical. You know, if you put a trapezoid patient with a square or a cylindrical clinician, you're not going to expect an outcome. It's like, you know, if we do a treatment to address a meniscus tear, but the problem is a cruciate ligament pathology, of course, we're not going to expect an outcome. So it's basically back to, you know, identifying the underlying pathology, back to the whole idea of triaging. And our underlying concept is such that, you know, not every patient is even as simple as a square or a rectangle or a cylinder. It's highly possible that your patient is more complicated. They might have a square problem and a cylindrical problem together. And if that's the case, then you either have to find a clinician or a physician who can treat both, or who can work together as part of a team so that everyone now can treat that patient in a highly patient-centered, clinically appropriate manner. So this is where we insert Dr. Clark's entire presentation, right? Because the most important tools to us as clinicians and physicians are the history, clinical examination, the experience of the clinician. So full disclosure here, prior to COVID, I had started really narrowing down or weaning down my hands-on clinical practice. And I started doing telemedicine consults for second opinions probably about 10 years ago. And one of the things that I always did as part of my normal clinical evaluation is I kind of prided myself on my examinations being so thorough. They would take a long time, and they were recorded that way as well. So I thought when I migrated to a digital format and telemedicine format that I would be missing something. Well, it turns out I do spend so much time really questioning the patient as to the underlying problem and getting so much information out about not just what the patient's complaining of, but also getting that information out. Remember, patients never volunteer all of the information. You normally have to extract it like we're skilled interrogators. And then even in a digital world today, doing a telemedicine consult, you can still do part of a clinical examination. You get to observe the patient, get to observe their behaviors. You can sometimes see things like muscle spasms and things like that, or antalgia as well. You know, technically I can do half of the cranial nerve evaluation digitally. But we also take advantage of people that might be with the patient. So a lot of times I'll have a family member, a friend, whoever's with them on the other end of the telemedicine consult, being my hands to help perform clinical evaluation maneuvers and things of the sort. Because the whole idea here is you do a history of the patient, and based on this thorough history of the patient, now we're considering that information, we're coming up with these are the most likely candidates, so we're going to do a problem-focused clinical examination to rule in or rule out what the problem might be, and then based on our experience, we are then making that patient-centered diagnosis again. Well, here's the problem. All too often, we're throwing darts at a patient, hoping that something is going to come out of that, and many times we even overshadow it. I think a couple of weeks ago, I got put on the witness protection program for the North American Spine Society because they had just come out with a new guideline for treating nonspecific back pain. And I responded with a letter to the editor, which Dr. Gooden probably saw, that basically said, well, wait a second. It turns out that I don't think that should be a diagnosis because every patient has a cause of their pain. We have a responsibility to better determine what that pathology might be so that we can make a more patient-centered, highly specified diagnosis for that patient and then determine what is best for them at that time. Thus, it's like drawing a bullseye on the target and then getting a better outcome. And that's the way that I look at a patient. So I take it personally when we just start throwing darts, hoping that we're going to get a response when most often that does not occur. But the problem with this is it takes time. So I don't know about you, but being in practice for 30 years, I don't recall ever getting a reimbursement increase for a CPT code. I've watched fees go down. As a matter of fact, reimbursement for the things that I do are a small fraction of what they used to be when I started practicing. Yet our cost for doing business as physicians has increased, right? So we're forced to see more and more patients, if we're accepting insurance, that is, more and more patients to keep the lights on. So you're spending less and less time with a patient. So then you start relying upon other technologies such as imaging studies to basically come up with information instead to substitute for that lack of a clinical examination. But this model is backwards because no one ever really had validity to that, or said that that MRI is definitively the answer. As a matter of fact, we'll talk about that in general with respect how the MRI goes, but this is about to get even more complicated anyway, because CMS, the beginning of this year, was supposed to start a new practice by which they would not approve imaging studies in certain conditions like back pain, or even for cardiac pathology, certain cardiac pathologies, unless you had the examination of the patient using this decision point tracking consideration formula to basically determine the need. So now the pendulum is going to swing back the other way because you're going to have to do the exam regardless if you want to get the imaging study ordered. So here's a study that was done, I think it was 1998, by Matsumoto. So what they did is they took 497, so we round that off to 500 individuals that were asymptomatic. So this asymptomatic population ranged from patients in their 20s, and patients, but they were just individuals in their 20s through 80s. So the results were, for males and females in their 20s, 17% male, 12% female, had disc pathologies on their MRI. And remember, these are asymptomatic patients. While 86 and 89% male, female, respectively, over the age of 60 had these same degenerative disc pathologies on their cervical MRI. So if you think about that, 90% of the patients over 60 years old had pathologies on their MRI that are identifiable and would have been red. Well, that's scary because they're asymptomatic. And strangely enough, the most important really citing of data in this study was the one that people paid the least attention to, which is that 7.6% of the subjects over 50 were identified as having severe cord compression that was indicative of the need to surgically decompress that patient. Well, who is going to surgically decompress an asymptomatic patient? Well, I kind of say that, but sometimes I think that does happen, but that's another story. So when we look at the neck and upper extremity pain potential causes, we have several different general classifications. Obviously, on the neuropathic side, you can have a myelopathy, problem within the spinal cord, radiculopathy, problem with the nerve root, plexopathy, problem with the plexus. There's a whole variety of different peripheral nerve entrapments, peripheral neuropathies, and a variety of different neuromuscular disorders. We have various joints. I mean, technically the neck is a joint, right? Because you have facet joints and then you have the disc spaces between vertebrae. But you also have your shoulder, your elbow, your wrist, and the joints within the fingers. So there's a lot of potential things going on here from the standpoint of arthropathies. We have tendons that can be pathological. We can have a tendinopathy, which is like a tendinosis or a sprain, or a tendinitis, enthesitis, which is an irritation at the insertion site. Think like medial epicondylitis or lateral epicondylitis, the golfers and tennis elbow. That is an enthesitis. You can have a muscular pathology as well. Aside from an actual myopathy or a strain, the muscular component can be secondary too, because if you have a nerve irritation that causes a muscle to become hypertonic, you're going to get lactic acid buildup in the muscle causing muscle pain, but it's secondary. It's not really primary. So it's not really a myopathy or a strain, but it's pathological or symptomatic at least. And we didn't even address things like vascular or autonomic components that can be causing a problem. And then what happens when these things start building on top of one another? Well, that's an entirely different story, because then it becomes even more complicated. So what I wanted to do with the first clinical case scenario here is give you a case that I think is among the most common that I see if I just had to pick out random cases for neck and upper extremity pain. So the first time I presented this case in a room with about 350 of you, when I asked, how many of you have seen this patient, almost everybody was raising their hands and nodding. So I think we got a pretty good case. So this is a patient who was probably about my age, so he was mid-50s, although now at the time I'm getting a little up there even more. But he had right-sided neck pain, suboccipital headaches, and a history of numbness and tingling in the 3rd through 5th digits, which had since resolved and is only problematic rarely when he has a very bad day. The mechanism of injury was he was shoveling snow outside of the place of business where he works. When he slipped, he lost his footing, fell backwards, hitting his head on what was said to be the snow-covered curb. And then he woke up, or got up from that with an immediate onset of a headache, and neck pain settled in within an hour or so. And then he had been dealing with this neck pain and headaches and upper extremity symptoms for more than the course of a year. So the first thing they did, obviously, when he went to the local doc in the box, was they did an x-rays, didn't find anything fractured, so they did an MRI. And the MRI basically showed, and I can blow that up for you. If you look right here, it showed a little bit of degenerative disc disease, and this is C2, 3, C4, so it's C5 and C6, and C6, C7 largely. So it's C3, C4, C4, C5, C5, C6. So, but nothing really severe. If you look really closely over here too, you can see that the canal was nice and wide open, and I'll point over here. So these are where the nerve root exits from the IVF, and he's got enough space here to drive a freight train through, even though this is the worst level of degenerative disc disease. But everyone sees the MRI report, which we know this degenerative disc disease did not set in a day ago. It took years to set in, so that automatically should be a flag for clinical relevance. But all of the treatment that he had subsequently for that was focused at the degenerative disc disease that was localized by the MRI. So he had a course of physical therapy, actually multiple, which included restorative type exercise, heat and massage, a variety of trigger point injections, usually into the trapezius muscle. He underwent 2 epidurals. He had facet blocks, which are actually medial branch blocks that they said were diagnostic, so they did radiofrequency ablations without long-term benefit as well. Side note here, I would argue even the radiofrequency ablation necessity, because if you sedate the patient when you do a medial branch block, then obviously you're getting a clinical benefit, but how did you separate that from it being from the anesthetic effect from the block? Well, that's another story too. So basically all of the treatment that he had was focused towards the mid-cervical spine, where you have the degenerative disc disease, and the trapezius muscle with respect to the trigger points. And then he was also given a migraine medication as well, because they put the diagnosis of migraines into the mix. So what we did is we did a clinical examination, and the revised clinical examination found tenderness along the nuchal line right here at the base of the head, where you have the insertion, or in this case, the origins of the trapezius, semispinalis capitis, and splenius capitis muscles. So this becomes the equivalent of an tendinitis or an enthesitis. We had hypertonicity in the trapezius muscle. Well, that everybody had seen with shoulder elevation, bringing the shoulder up. When you palpated the neck, and all of you can do this right now yourself, if you take your fingers and fan them out on the back of your neck right over here, you can feel what is largely the multifidus musculature around the neck. And if you feel one spot where it feels like there's a knot, that's a multifidus muscle spasm. And if in that little area you can find one focal area pain that's exquisitely painful as well, that might be a facet that's inflamed. So you can easily palpate the neck and find that he had a tenderness or an irritation of the facet joint at C3, C4 on the right. He had pain at the costovertebral joint. When you pushed on the costovertebral joint, the patient would yelp like a squeeze toy. And any place that you pressed along the second rib also caused pain and discomfort. So he basically had what we call a rib arthropathy, but there's a number of different terms for it. Strangely enough, the balance of the clinical examination was relatively normal. Normal DTRs, motor sensory examination, cervical range of motion seemed to be intact and normal. Phelan's, Edson's, Wright, Snell's, cervical compression, Jacksonian compression, and cervical distraction, all normal. And that's the basis of a pretty decent cursory clinical examination. But if you notice, and I'll go back to that, the areas that were most identified as being most severe by the patient as far as his pain was at the base of his head, headaches, and the base of his neck, where his cervical spine joins the top of the shoulders. And that's exactly where the clinical examination was pointing to pathologies. So we now had a revised working clinical diagnosis. That was suboccipital headaches, thanks to the tendonitis enthesitis, right? But there was a small possibility of involvement of the greater occipital nerve, right? But if you had headaches where the greater occipital nerve was involved, more often than not, you will get a pain. And I think I can blow that up just to show you, because there's probably a little branch in there. Yeah, you can see the greater occipital nerve going around the top of the head. So you would typically get radiation following that distribution. So even though it's clinically plausible, it wasn't likely because it wasn't in the patient's complaints. So you can drill that out. He had a right second rib arthropathy. Now, the right second rib arthropathy can be problematic here for two reasons. You can cause a myofascial entrapment thanks to muscle spasms that will occur in the shoulder because of this rib arthropathy, which are going to include the pec minor muscle, which so you can technically cause essentially like a functional thoracic outlet syndrome, which can give you the numbness and tingling following that C8T1 distribution. But you can also irritate the nerve root, causing a mild radiculitis as it exits the spine. So you have a couple of different possibilities there. And we have certain ways of differentially diagnosing that if I have to drill that out as well. And typically I'll do something like an evoked potential for that. But it's getting really hard to find people to do evoked potentials these days. And of course, we had the right C3, C4 facet irritation contributing to the tendonitis, enthesitis at the base of the head, and the pain in the trapezius. So that little facet joint was causing a couple of things, or contributing to a couple of things, including the headache and the shoulder pain. So our revised working treatment plan now for this patient became topical diclofenac, which at the time was completely off-label, but technically it's still off-label because of the fact that it wasn't for an arthritic type joint problem. It was for a tendonitis enthesitis. Manipulation to adjust the rib arthropathy, very easy to do. If it's a relatively mild case, we do manipulation without any form of injection. If it's more severe or something's more inflamed or it's been there for a long period of time, a lot of times we'll combine it with either an interventional or a non-interventional injection to help facilitate a better reduction for the manipulation. And lastly, an intra-articular facet injection at C3, C4 to help address the C3, C4 facet inflammation. Now, going forward from that, we also did a couple of other things. Now we have to apply a lot of what Dr. Clark was talking about too, because we have to look at the biopsychosocial side. So here you have a patient who's already gone through treatment by a dozen different providers over the course of a period of time greater than a year, and the patients become frustrated too because they don't even know who to believe or what to believe anymore. So you have to explain everything to the patient, giving them enough information to have confidence in this new information that we're providing. So I walk a patient through the examination. I show the patient the images that we're discussing today and give them the rationale, because they're going to be in for a shock as we say, okay, in this case, we're going to be working on discontinuing your medications because I don't think you need the migraine medication. I don't think you need the neuropathic pain medication, and I don't think you need the opiate anymore. And we start weaning the patient off. So theoretically, it took longer to wean the patient off the medications than it did to treat the underlying pathology, which is kind of scary. And then we're giving the patient, the knowledge, the awareness, and the education to help promote this biopsychosocial side of treating the patient, so that the patient's becoming part of their own treatment as well. And then I think you went for one single follow-up for manipulation after the treatment. that initial treatment on that day, but otherwise did really well. So within a month or two after we saw him, the case was closed. So the reality here is, while providing valuable information relative to structure, the MRI or any imaging study does not tell you whether that pathology is clinically relevant. That comes from the clinical examination and your clinical experience, and you have to really make that call, because it's frustrating when people go down that red herring sort of path with all sorts of unnecessary treatment. I'm dealing with a case that I just did a review on for, I think, a 22, 24-year-old kid, young man, who ended up having a multiple level fusion in his back. And now he has a more of a complex regional pain syndrome pathology in the lower extremity. But I'm looking at it thinking, I can see where the hardware was done and why it's there. It makes sense to me. But I looked at the pre-surgical MRI, and I don't know that that was causing his pathology to begin with. So, what did we do here? And in over 30 years of seeing MRI results, I think I've looked at 20,000 MRI or imaging study results. I've never seen radiculitis specified as an MRI interpretation, but yet that's what we're treating all the time when we treat these patients with NSAIDs and steroids and interventional injections, many interventional injections, and even manipulation theoretically. It's to correct a pathology that's causing aberrance, of which inflammation is part of the process. So all of us remember the brachial plexus, right? So here's an interesting fact. The brachial plexus is made up of or comprised of the C5 through T1 spinal nerve roots. And if you remember your dermatome, C5 is like the lateral arm, C6 is lateral forearm, first and second digit, C7 middle finger, C8 fourth and fifth digits, T1 sort of medial forearm. All of the muscles for grip come from the medial elbow, as in ulnar nerve distribution, C8, T1, right? All of the intrinsic muscles of the hand that allow you to abduct or, for opposition of the thumb are also C8, T1 innervation. So would it be safe to say that if you have a patient who has numbness and tingling in the fourth and fifth digits, or decreased grip strength, or any weakness with finger abduction, adduction, that there is a problem likely involving the C8 distribution? And the answer is yes. As a matter of fact, you ever have a patient say they have tingling in all of their fingers? Is it possible it's more of a peripheral neuropathy type issue, or a plexopathy, or a vascular component? Sure, but it can also be a proprioceptive distribution, not nociceptive distribution of pain. Think C8T1 for pain, tingling, or numbness in all of the fingertips. That's also another discussion. So here's an interesting factoid. Up until a couple of years ago, many of the cervical MRIs that were done will cut off the axial slices, the slice you see here in the middle of the screen, at the body of C7. Well, if you cut it off at the body of C7, you're right above the C8 nerve root, and then T1 comes out between C8 and T1. So you wouldn't even be close to getting the T1 nerve root. So if you ever order a cervical MRI for any kind of a neck and upper extremity pathology, always write on the order, please include axial images to include the C8 and T1 nerve roots. Otherwise, if you don't ask for it, you're not going to get it, because even though it might not necessarily be clinically relevant, you at least want to make sure you're looking in the right direction. So I started mentioning this probably about 5 or 6, if not a little more, years ago. And it turns out that a lot of you are bringing this information back to your hospitals, your MRI facilities, your imaging centers, and they're making procedural changes. So we're actually winning the war on getting people to change the format or the structure in which they build the study to begin with. So who knows, maybe at some point someone's going to realize the relevance of the anatomy and make those changes system-wide. So I want to talk a minute about facet joint irritation here, because that was extremely relative when you talk about this last patient that we just saw. So when you have inflammation of a facet joint, you're going to get actual joint pain. I think we can all agree to that. You can get local muscle spasms as well for 2 reasons. You can have muscles that go into spasm to act as a guarding mechanism, i.e. like the multifidus muscles that are trying to protect movement at that area because of inflammation. But you can also get muscle spasms as a result of the nerve being irritated. Because if you irritate a nerve, that nerve is going to basically fire, these little random impulses that are going to cause the muscle to become hypertonic. So let's blow that up a second because it'll actually be easier to see. So if you look at the facet joint and you see the close proximity of the nerve root, as that facet joint's inflamed, you get the release of inflammatory cytokines like tumor necrosis factor alpha and a bunch of others that then cause the nerve root to become inflamed. And in the cervical spine, where the IVF is actually very small, where the nerve root exits, it can actually start compressing upon itself and result in a compressive radiculopathy to boot. So I'm going to give a little clinical pearl here too, based on my clinical experience. So over the years, I've probably done 10,000 plus evoked potential studies, but probably thousands of patients that had facet inflammation. And on those patients, we often talk about referred pain from a facet joint. Well, I'm going to tell you that on every single one of those patients I ever did, I would always find at least a low-grade radiculitis. So I don't necessarily believe it's referred pain from the facet joint. I think the facet joint is actually inflaming the nerve root. And we've proven that fact just as many times because we've blocked those nerve roots all too often as well. And also blocked the facet joint too. But we've also done things like transforaminal epidurals or something along those lines that are specific nerve root blocks to block that too. So the muscle that's innervated by that nerve that's getting inflamed can also be contributing to the referred pain too. And that was the case with this patient with the trapezius muscle spasm, because remember the trapezius is innervated by the spinal accessory nerve, which is cranial nerve, but it also has a somatic innervation as well, which is C4, C5 from the C3, C4, and C4, C5 spinal levels. So here's another patient. This patient basically has compression of the C6 nerve root. I'm going to blow that up. So if you look at this patient, you can see here that the nerve root is being compressed as it exits the IVF. So when you look at an axial image, by the way, it's reversed as if you're looking at the patient from head on. So the patient's left is actually on the right. See the R here, that means this is the patient's right side. So this patient has a compressive radiculopathy of C6 nerve root. And you can see here on the lateral, it doesn't look so good either. So this patient, if you think about this, is going to have a couple of things going on. They're going to have a protection mechanism there that says don't move because you're going to create worse of a pathology. So what happens is you get muscle guarding. You are also going to get somewhat of an antalgia with the patient like leaning forward, let's say, to try and take pressure off the nerve. But that nerve being compressed is also going to have a pathological downside, which is going to give you axonal loss, a conduction block, and maybe even a phaptic transmission. And that phaptic transmission is also probably likely what's contributing to the hypertonicity or muscle spasms following that distribution. But you can also get motor weakness. And of course, you're usually going to get pain, numbness, tingling thanks to the axonal loss and conduction block. So this is a patient that requires a surgical decompression. And I think that that's key. When you see something like this, there is no conservative therapy that's going to help that. And even if you did get an injection in the area in the form of an interlaminar epidural, in this case, I would always suggest like a catheter-guided interlaminar epidural to get the medication right to the nerve root. Back in the old days, we would have done a selective nerve root block or a transforaminal, but nobody likes to do those in the cervical spine these days. So you might have gotten an anesthetic block and might be short term, but you're not going to fix the problem. So this requires a surgical decompression. But you contrast it with a patient such as this. So let's blow this one up. So when you look at the degenerative disc disease here in the mid-cervical spine and you read the report, things sound really bad. Almost as bad as it did when you looked at the report for that last patient that I just saw you. But on the other hand, if you look at the individual nerve root levels, and we can blow those up too, I think I can get them all on the same screen. And there you go. You can see the worst of them is C5, C6, but even with the broad flattening of that disc at C5, C6 and the flattening of the cord, there is still plenty of room for the nerve roots to get out. So there is some degree of canal and spinal stenosis, but it's not necessarily to the degree that it was at the other patient, which is surgical only. And if you look at the other two levels, you can see we have plenty of space. So with this particular patient, we're having this conversation. He's showing me the MRI and telling me what he has scheduled for surgery. And I'm watching here, I'm observing him just like you can online, right? And it turns out he had a CT scan as well. So I'm thinking that I don't think that that disc herniation or those disc herniations are necessarily contributing to his pathology, because he's not behaving like I would expect him to do if he had nerve root compression. So when you look at the CT scan, now, if you ever order a CT scan, another clinical pearl here, always ask for 3D rendering, because what you'll get back, in addition to the normal 2D slices, is you'll get back this computer generated image that you can rotate around at a different axis. So it looks like we've built a model, three-dimensional model of the patient's spine. So when you do that, if you look really closely, you can see that the facet joint here, if this is C2, C3, so C3, C4 on the left side of your screen, C4, C5 on the right, and you can see when you look at, step back and look at the whole thing, you can see those two facet joints look like they're inflamed. Well, when the patient looks at you and you're seeing the observing the features of that examination or that observation that look more facet mediated, and you place your fingers over the back of their cervical spine and you can palpate the facet joints that are tender, I'm thinking that this is the clinically relevant pathology. So it turns out that's what he had. And he ended up getting a facet block instead of surgical fusion, and then did really well. And the other thing about the CT scan, by the way, too, is you can rotate it around so you can see it from different views, which is nice to have, especially if you're like me, where you like seeing these three-dimensional images, but it makes it easier to see in the plain world as well. So if you ever do a CT scan again, please include 3D rendering. The novel thing about that, by the way, is that they'll bill for it. Insurance companies usually don't pay for it. So the patient ends up getting the 3D rendering at no additional cost, and it's no exposure to the patient because it's merely a software building of the different images to get the 3D view. So when I got started in clinical practice, the two patients that I was seeing the most of back in the good old years in 1990 were post-op carpal tunnel syndrome and post-op back pain. So I wasn't seeing easy patients from the get-go. And one of the things that we looked at on the carpal tunnel syndrome side was we were trying to predict or account for why all these patients we were seeing turned out not to have carpal tunnel, or if they did, they still had an underlying cervical radiculopathy or something else going on. So it turns out that the best way to explain this was something as simple as the garden hose theory. So we all know what happens when you bend a garden hose, you decrease the water coming out, right? But what happens when you bend that hose the second time? Well, if you bend it the second time, then obviously it's going to stop. So here's the kicker. If you looked at nerve function is normally 100%, right? But if you take your wrist and bend it at 90 degrees, you're kinking the median nerve right here at the wrist. So you're probably decreasing that nerve's ability to function by about 70%, plus or minus a few. But the body says, hey, I only need 60% to work in a normal situation. That's why when you bend your hand, your fingers aren't going numb, right? But let's say you get a cervical radiculopathy or radiculitis all of a sudden, so the whole nerve is now working maybe at 80%. Well, it's sort of above that threshold, so you're not symptomatic. But now when you bend your wrist at 90 degrees, that drops it to like 40 or 50%. And remember, these numbers are strictly arbitrary. I'm just using them for discussion purposes. So now that it dropped it below that clinical threshold, all of a sudden now I'm getting symptoms in my fingers that are like carpal tunnel syndrome. So the question is the pathology at the wrist, or is it higher up the line? And that's the key. So when we mapped it out, we actually found out that the lion's share of the problems, almost 40-some%, were at C6. But the next largest number was quite surprising because it was, I think, 39%. And then there was a position of T1 in there too, which together, the two of them comprised almost 50% of the pathologies, which could account for why these patients often, when the carpal tunnel syndrome decompression didn't work, they went for an ulnar nerve decompression at the elbow, which is C8T1. The other point I should mention there too is that C8T1, for the median nerve is what gives you motor innervation for the opponent's pollicis brevis and the lumbrical muscles that allow you for abduction, adduction in your hand. Even though they're median nerve innervation for this part of the hand, the nerve distribution for that myotomic innervation is C8T1. So that kind of makes sense. So basically, another example of this is, think about a fire hose and a fire truck putting out a fire. If you try and step on that hose, it would be the equivalent of trying to step on a hard pipe. You're not going to compress it. But if a truck drove over the hose and then you walk, even though water's still coming out, but then you walk over to the hose and you can step on it, you can compress it, and then maybe interfere with the flow. So the presence of the proximal lesion makes the distal pathology more suspect or more susceptible to a problem. And then the two pathologies together can become cumulative, and that becomes a nightmare. But if you are always just going after the latter distal one alone, you're never going to be able to get an effective treatment for the patient. And we'll see that even in the case of not necessarily a carpal tunnel. You can cross pathologies as well. Like, what happens if you have a patient who has a diabetic neuropathy, and then all of a sudden you get a lumbar radiculopathy on top of that, because they're not mutually exclusive. So that makes your whole clinical presentation even much more complicated, because the underlying pathology makes it more susceptible for another pathology to aggravate the patient. So you have to tease out then what might be the most important thing or most appropriate thing to do. And sometimes those patients then require looking at them from two different perspectives and addressing them both concurrently. So the double crush idea is not like a random thing that appeared in literature. There are hundreds of published Index Medical Journal articles that support it. And in a strong, uniform way. I just gave you a small sampling, but you can always look them up on your own. So what that basically says is, even if you have a patient who has symptoms in their hand alone, you still have to look at the entire patient when you do that exam. So you still have to look at the elbow, the shoulder, and the neck. So there is no such thing as taking the easy way out and doing just the hand alone. And I can't tell you how often, more than not, when we see these patients that have long-term chronic problems, that the problem is someplace else. So always look at the whole patient. Rotator cuff tears are another good example, right? So I had an interesting example of this the other day, and if I can get to it, I'll tell you. But Hiroshi did this study whereby in 2013, they looked at the prevalence in a whole entire town or city, one village, where they did MRIs on everybody. So that's from ages 2 to 80 were their population. So when they did that, they basically found symptomatic rotator cuff tears in only 34% of the tears, but they found asymptomatic tears to make up 65.3%. Well, that's kind of problematic, because that's telling you that you are 2 times more likely to have an asymptomatic tear than you are to have a symptomatic tear. And the prevalence was worse as you became older in years as well, because once you got above 50, 60, it accounted for the asymptomatic tears accounted for 2/3 of all of the tears. So you had a high prevalence of having tears, whether you were symptom or not. And then the older you got, you were more likely to have tears that were asymptomatic. So how do you know that just because you have a tear, that that's the underlying pathology? So the case I was going to tell you about was the second opinion I did just a couple of weeks ago, whereby in this telemedicine age, the patient developed symptoms. They were referred to an orthopedic surgeon who, first thing he did was do a quick telemedicine consult, ordered an MRI, and the MRI showed a rotator cuff tear. So they gave the patient the opportunity of scheduling him for surgery or physical therapy that he didn't think would help. Well, meanwhile, I don't think it was effective, because if you talk to the patient, I don't think the rotator cuff had anything to do with his pain, which is a whole nother issue. So that becomes problematic, is just because the tear was there in imaging doesn't mean that that is the underlying pathology. Another similar study by Siebert and his group basically just plotted out the prevalence of asymptomatic tears being part of the normal degenerative process that were age-related. And their numbers were a little bit less strong as far as prevalence numbers than the study before, but they're still high. So there's two books that I keep on my shelf. Great plug for the books, I guess, by Steve Waldman. One is the Atlas of Common Pain Syndromes. The other is the Atlas of Uncommon Pain Syndromes. And if you look up shoulder conditions alone, on the common side, you see degenerative arthritis, rotator cuff pathologies, AC joint problems, subdeltoid bursitis, biceps tendonitis, supraspinatus tendonitis, deltoid syndrome, scapulocostal syndrome, which is what we call a rib arthropathy. On the uncommon conditions, you have suprascapular nerve entrapment, supraspinatus tendonitis, infraspinatus tendonitis, subacromial impingement syndromes, osocromiality, which is the non-fusion of the acromion, pec major tears, quadrilateral space entrapments. So you have even more than what's out here. But how do you know what's causing the problem until you examine the patient? And I thought that other patient that when I was talking to him actually had a biceps tendonitis. So that was my take. And I was recommending that he get that injected and then see what happens before he schedules surgery. So I don't know where that's going yet, but we shall soon find out. So again, hands-on examination by a skilled clinician is essential and has to provide the differential diagnosis. You cannot rely on imaging studies alone. So here's an interesting case, and I put this here so you can see how this gets played out. So this was a 21-year-old college student who was complaining of right-sided shoulder pain that was reported as deep and aching, and he perceived some weakness in the shoulder, but it was hard to nail down. But he was a musician, and he complained it was interfering with his ability to play whatever instrument that was, because I actually forgot. And then the pain was also aggravated with certain movements of the neck and shoulder. So the first thing they did was an MRI of his shoulder, and the MRI came back negative. So the orthopedic surgeon said, well, let's do an MRI of your cervical spine, and that came back negative as well. So they referred him to the PM&R guy in the practice that does EMGs, and they did an EMG of the upper extremity, and the diagnosis was carpal tunnel syndrome. So here's the problem. If you remember the brachial plexus that we talked about, well, the EMG of the upper extremity involved this particular cookie cutter study. So it's a typical cookie cutter study, but the problem that you run into is even when you do an EMG, you're supposed to examine the patient and then tailor the study to the patient's exam. But what we all see all too often is that every patient gets the same study no matter what. And that could be problematic because I can give you dozens and dozens of cases where the patient had a pathology that showed up on an EMG, but not on this cookie cutter EMG, because you had to do other muscle groups in order to identify the problem, or even stimulate other nerves if you're doing a nerve conduction study. And this is one of those cases. So the patient comes in and he tells me about his shoulder pain, and I'm okay with that. And I said, so, okay, tell me about the problem, the carpal tunnel syndrome. And he says, well, I have carpal tunnel syndrome. So there's a teaching moment here, right? So first thing I did is I opened up the page in Waldman's book to carpal tunnel syndrome, because all he would tell me is he had carpal tunnel. And by the way, he was undergoing physical therapy several times a week for carpal tunnel syndrome. So I opened up the page in Waldman's book to carpal tunnel and show him the picture, and he reads it and looks at it and says, well, I don't have that. And I said, well, that's the point I'm trying to make. So he says, well, why do I have to wear this? And he shows me his cock-up splint, and I was just smiling because he didn't even have symptoms in his hand. So I said, okay, we have a good teaching moment here. And I flipped to the pages in Waldman's book where he showed a suprascapular nerve root entrapment. So I said, okay, this is what I think you have, but there's a couple of variations to the theme. So let's see if we can tease out which it is. So I did an EMG on the patient as well, but I did the supraspinatus and infraspinatus muscles. And then for evaluating the nerve side, instead of doing median, ulnar, and radial nerves, which are clinically irrelevant to this particular patient, I actually stimulated the suprascapular nerve, but I did the inferior and superior branches using an evoked potential. So I was able to come out and definitively say it was affecting the superior branch distal to the bifurcation as it innervates the supraspinatus alone. So then I pretty much drew an X on the spot, sent him back to his primary care doc and said, inject here, with a copy of the page from Waldman's text, and then told the patient to stop wearing a backpack. So you see how that patient-centered evaluation sort of works, where you take a step backwards and you look at the entire patient. But how do you even make excuses for the carpal tunnel syndrome diagnosis and therapy when the patient didn't even have a complaint there? That's a whole nother issue. So one of the things you have to remember about EMGs is preganglionic sensory radiculopathies can be missed by an EMG anyway, because the primary focus of the EMG is to stimulate the muscle. So if it's preganglionic, the distal nerve is intact. And if it's sensory only, the muscle part of the equation is normal. So just because you have a normal EMG doesn't mean it's asymptomatic. In addition to, or the patient is asymptomatic or non-pathological, in addition to the fact that the cookie cutter study might not identify the pathology because it wasn't tailored properly to the patient. So here's another case for you. This was an interesting one because there's a joke here, and I'll tell you what it is. So this is a 47-year-old male who was involved in a motor vehicle accident. And what he ended up with was an immediate onset of pain that was shock-like at the base of his neck. And it would cause knife-like shooting pains into his upper extremity as well as at the base of the neck. And then we were a couple of weeks into this, so by then he also experienced pain that radiated up the neck and headaches. Weakness in the upper extremity. So it had really developed into something more severe. And he was pretty antalgic. He didn't like moving his head around at all. And the slightest little movement causing shock-like pain. So he was kind of talking to you with his head down and tilted and turned to one side. So 6 months had gone by the time I had seen this patient. All right, the running joke is here, this was an iatrogenic problem because he was a car salesman and a physician was driving the car at the time he slammed into a tree or something. So anyway, here is the x-rays, which were unremarkable. The MRI showed mild degenerative disc disease, C3, C4, C4, C5. So here is your EMG findings, your MRI findings. You can see these are very mild findings. They're not that severe. And again, there's nothing to indicate that that happened during the course of the injury. It's more something that occurred over time. So the neurologist that he was referred to attempted to do an EMG on the patient, but the patient was so sensitized because remember, central sensitization, peripheral sensitization setting in. So you couldn't even breathe on this patient without causing more exquisite pain. So he thought he would send the patient to me to try and do an evoked potential, which I did. So we have some tricks when we do an evoked potential that can numb the stimulation site. Otherwise, it's pretty uncomfortable. But you can use a little lidocaine or something where you stimulate the nerves and then it takes the edge off, so it's not too bad. So the SCP, or the evoked potential, identified a T1 radiculitis. All right, so I've seen this before. And the reason why I've seen this before is if you have a fracture of like a vertebra or a pedicle or something along those lines and it's close to the nerve root, the movement, just like you would if you broke your arm at that small segment, can cause pain because the periosteum of bone is extremely highly nerve innervated. But there's also going to be an inflammatory process, just like we have with the facet irritation, that can cause the nerve root to become inflamed. So I've seen this pathology, but if you look at the MRI slices, look what slice they missed. So the T1 nerve root was not imaged, but they did include C8 on this one. So I asked for the MRI to be repeated and they wouldn't do it. So then I asked for a CT scan because I'm thinking, okay, there's probably a vertebral fracture anyway. I want to get that on imaging. They refused to do that as well, but they agreed to do, strangely enough, a bone scan. So for those of you who know what a bone scan is, basically you give the patient this sort of radioactive substance, and then any place this substance is metabolized, it kind of puts a tag into the area that when you put the patient on an imager, you're either going to see greater absorption in that place if there's extra metabolic processes going on, or you can see an infarct or a lack of a process where you expect one. So remember I said the patient had an antalgic position where they were stuck with their head stuck forward and tilted to one side? Well, the problem is he couldn't lie flat on the exam table, and you can see that in the actual image. So they put pillows under his head and shoulder when he's on the imaging table. But if you take the patient off the imaging table, the area that you're trying to image, you've now made it inconclusive. So the interpretation from the bone scan came back, and I kid you not, arthritis of the right ankle. So it turns out that that patient did have a T1 fracture, and I didn't get to confirm it until 3 years later, because we managed it accordingly. We gave him a block, we gave him some medications, and we walked it through, and he did okay long term. And then he gets hurt in another car accident 3 years later. When he came in with the new imaging study, I can see the healing of the fracture on the bone, so I knew we were right, and we had to treat him now. All right, so the reality is that the clinical relevance of any diagnostic procedure is never 100%. So we have to take it in stride and look at the clinical relevance. The study itself can be defective from the standpoint of deficient in its ability to identify the pathology because it wasn't structured right. But it also could be that it's just limited in its availability or ability to identify that pathology. So it could be inadequate, you didn't hit the right level, like when we didn't image enough, or the adequate levels in the cervical MRI for C8 and T1, or maybe think like the EMG that didn't look at the right levels, or the technical considerations like the bone scan that had the patient off the imaging table. So there is nothing that should ever take the place of a clinical examination and the adequate history that you get a lot of information out. And you also can't look at negative test results to say, well, that rules out a problem, because again, you have these same considerations, because it just might be limited in its ability to identify that pathology. So you're kind of stuck in the middle. You have to really evaluate the patient. And where it becomes more complicated, again, is where you have overlapping pathologies that are then contributing to a clinical presentation, like our first case that had headaches, but that he had an underlying facet pathology, a rib arthropathy, and a tendonitis enthesitis. So lastly, remember, you can't just look at a single body part. You can't just look at the wrist, can't just look at the elbow, can't just look at the neck. You should always look at the patient as a whole, because everything is connected. So that's kind of our take home, and that's sort of the balance of this session. So with that, I'd like to invite Dr. Clark back for the Q&A. Hi, Dr. Clark.
Hi, David.
I don't know if you had the opportunity to listen in there, but did I speak fast enough, or was I slow enough so you can understand?
No, it's perfect.
All right. So let's see if we have any questions. We have a patch left. We have a question for the patches. Could the patches be used conditioning post-lap like tap block for laparoscopic procedures? I'm not even going to address that one. That would have to be one for Dr. Gooden. Dr. Gooden, are you there? Can you take that question? I see him logged in still. We can bring him back. All right, so I'll have to invite questions. If not, you and I are going to have to come up with a good discussion point. But I don't see any coming in. So we either did one of two things. We either were so thorough in our presentations that we answered everybody's questions thoroughly, or everybody fell asleep.
Could be either one.
Well, it is Saturday, and I think the one thing that we didn't do that Dr. Gooden did is we didn't have dance tunes to keep everybody live. Maybe we should include that into our presentation. All right. Well, if there are no questions, then I guess we can close. So I would like to take the opportunity to thank everybody for giving us part of your Saturday afternoon. I would encourage everyone to visit the PAINWeek.org website to look at the schedule for future PAINWeek Premiere programs, and remind you that the additional online enduring content for the virtual PAINWeek meeting that we had this year should be available in a couple of days as well. So you have a lot of opportunity to get continuing education, not only for the sessions that we're providing you today, but for other sessions from our respected speakers and our entire faculty for PAINWeek. There is a variety of other references or resources that you have also on the PAINWeek website, so I highly encourage you to visit. And with that, I guess we can conclude and remind everybody that you will expect to see an email in your inbox within a few days. You just click on the link in the email, answer the couple of questions that they give you for the survey, and you'll be able to save and print your CE certificate. Wow, we got a couple of questions. Okay. I emailed one. Great job. Thank you. Is your contact information on the slides? I have a question. My contact information is you can always get me at DG, my initials, at painrx.net. So that's DG at painrx.net, and I will gladly take that. And in case that question is for you, Dr. Clark, because it doesn't say, do you have the best contact information?
Yes, you can email me at michael.clark@inova.org.
That'll work. And say I have a friend with muscle weakness at C8T1. For that patient who asked the question, the best thing to do is if you want to call me about it, I have no problems, and I probably do more of these a week than I do with actual patient second opinions. But I probably spend more time talking to physicians and clinicians who call me about their, a complicated case or something that they want to run by me, and my door is always open to do that. So whoever wrote that question about the patient with that distribution of a problem, please give me a call. I'm more than happy to talk about it with you and see if we can get some guidance for what you can do to help either better evaluate it or maybe make some recommendations for treatment based on the observations and exam findings you may have. Anything else, or is that it? No, wait, we got some more. Nope, that was pretty much about it.
David, maybe I could just tell you a case that was referred to me and see if you have anything to add to it. This is a 28-year-old young man who works in an office practice of doing joint ventures and venture capital deals. So he spends a lot of time at a computer, but he has a standing desk. He has no particular injury. He is fairly active as far as walking, exercising, no heavy weightlifting, and was sent to me really for depression and difficulty functioning. He has a long history of OCD and attention deficit disorder managed quite well with stimulants, and had been put on an antidepressant, Lexapro, which he initially responded to, but then that seemed to fade. So I've been working with him on the antidepressant side to try and get his mood more stable. But his pain complaint is really in that center of the scapula, just off the edge, about parallel to C8 or so. And like the other cases you've presented, he's had an MRI, plain films. He's been examined by an anesthesiologist, pain specialist, as well as a PM&R physician. The pain is fairly localized, and there is some, in his mind, point tenderness, but every study has been negative. Nothing has worked to alleviate his pain, and he pretty much describes it as being constant. Any recommendations, thoughts, people he should see other than you?
That's pretty funny, actually. So the first thing that comes to mind if we play the numbers game on that patient, because remember, it's all based on our experiences. So my experience tends to be a little bit unique sometimes because these are the typical patients that I see, and you become very good at seeing or working with the patients that you see most often. So that patient is typical of the one that we gave as an example here that I think has like an irritation at the costovertebral joint or the rib arthropathy. So if you took the patient's hand and had them cross their hand to the opposite shoulder, so you pull the scapula a little bit further away from the spine, you can palpate out when you hit that costovertebral joint, the patient's going to say, ouch. And then you can generally go in. I mean, the second rib is the most common. The second most common is actually the fourth, followed by the third and then the first. So that you'll probably see something and you can palpate both sides. And if that turns out to be the case, a common cause of doing that turns out to be like a lifting injury. So that if you lifted up something with your arm extended, because of the way the muscles in your shoulder girdle attach to your shoulder, like the pec minor attached to the rib, you can actually cause that rib to be problematic just because you messed around with the articulation, let's say while you were inhaling more so than exhaling, And now that it's gotten irritated, the little intercostal muscles and multifidus muscles help maintain it because it knows that something's wrong and becomes self-perpetuating until you go in and do something as simple as manipulate it. So if the patient has had their problem, again, for a very short period of time, like several months, you send them to an osteopath or a chiropractor or a physical therapist who does mobilization even. And if they can manipulate that area to reset that articulation, you're in great shape. If it's been there more than 6 months and it's become quite chronic, then the degree of inflammation is probably a little bit more severe than my experience says manipulation alone would help. And typically we're injecting it, either a medial branch block at the level of multifidus muscles, or sometimes just a local trigger point injection before you do the manipulation, and then you would see a response. But I'd be really curious. You'll have to follow up with me and
Absolutely.
what happens when the patient comes in next time if it turns out to be that, because that's the first thing that comes to my mind. We had a
Right.
case, just to give you an idea of the referred pain scenario for that, we had a case at when I was doing I forgot the name of the thing I was doing when I was at Evans Army Community Hospital at Fort Carson, Colorado, where we had a soldier who came in that was evaluated for chest pain. So they had every test known to man done to evaluate his chest pain, and it was basically diagnosed as non-cardiac. So we looked at him and found a rib arthropathy, injected it, manipulated it, and he was back at full duty. And this is somebody who was about to be discharged or go through the discharge process because they thought he had a cardiac problem that they couldn't nail down. And it was something very simple. So that was one of the ones that came to mind. Let's see.
Nice.
How do you measure patient-focused outcomes? I know how I do that. You look at the patient. Every patient is their own case study. So if I see something that's positive on that patient when I do my clinical examination, I measure the outcome by looking at what was positive or what changed the next time I see them. So you don't have to do that whole long drawn out clinical exam that you did initially, but you now have what the normal base rate is for that patient, if you will. So you set the stage for what to evaluate for following up. So if we took care of your patient and they came in for a follow-up 2 weeks later, the first thing I'm going to look at is, was that still tender when I palpated? Was there any other weaknesses or other things that were positive when I looked at that shoulder exam that were indicative of something that helped support my diagnosis, and what happened with those changes as well? And then if all continue to do well, then you look at, now how do we address the medication side to really minimize what we don't need to treat severely anymore, if that makes sense. So we get to back off some of the meds too. And that's where we are. Let's see. An EMG was abnormal. Let's see. If an EMG is abnormal, does it ever return to normal? PT probably diagnosed plexitis by EMG years later normal. Of course. An EMG can change just like anything can change. If you had a pathology that was there and the pathology healed, over time it's going to improve. So the answer is yes. Now, it's not always going to improve if the pathology remains. I think when I do the pain mechanism session, I use the example of sticking a spear in the foot. So if the spear is in the foot and we're evaluating the patient 2 years later and the spear is still there, then obviously we're going to expect the same positive findings. But if we take the spear out and time has set in and things healed, then of course it can be better. And that's our goal, right? Treating the patient. Let's see, was there another, or was that the end? I think, let's see. Would a patch help severe neck pain spasms due to cervical nerve root impingement? Ooh, did Dr. Good never come back, or should I answer that? So there's a difference between therapeutic, I think, from the standpoint of mitigating symptoms versus therapeutic to treat the pathology. So if the patch is helping to mitigate the experience of the perception of some of the symptoms, then that would be fine, but the patch would not do anything to, I think, treat that cervical root impingement. You're just helping mitigate the experience of the symptoms. So then theoretically it has a therapeutic component, but it's therapeutic for ameliorating the symptoms sort of like an adjuvant, but not treating the underlying pathology.
David, Heather forwarded a question through the chat box. She said, this is a hypothetical scenario. The patient needs a controlled medication refill, but the provider is out of the office for a few days. Do you allow another provider in the practice to provide that refill, or just enough until the original provider returns?
That's one for you. I know what I'm going to say, and people are not going to agree with what I have to say. So I'm going to leave that one for you.
All right. Well, I think it also really depends on the individual patient. And I would hope that the providers in the practice would have anticipated this and talked about the situation so that the practice itself is consistent. However, what I would tend to say, number one, I would want to make sure that the patient hasn't run out early. And assuming that that's not the case, then we need to think about what's the process for the practice to make sure that, you know, these things don't happen frequently for all patients, because patients get very anxious and fixated on running out of medicine and not being able to get an appropriate refill. If all of that has been done and the patient has been compliant in the past, has been meeting all of the requirements of the opioid agreement, et cetera, et cetera, et cetera, then I would probably let one of the partners refill the prescription, but I would flag that in the chart. In the event that something else happened, then I might come back to this instance and say, maybe this is the starting point of something that is going sideways. If the patient has had difficulty in the practice, has not followed the guidelines, then I would probably just provide enough medication until the original prescriber's back. And I would ask the patient to schedule an appointment with that provider so that they can really address the situation and what happened more thoroughly. The patient won't like that, and they'll have a variety of reasons for why that might be a problem for them. But I think that that just furthers the conversation as to why are these things happening, and maybe we've missed something, and we really do care about you and making sure that your outcome is good. And so we just want to make sure that we're turning over every stone and doing our best to make sure you don't fall through the cracks.
And I think the good news about the one good news factor of this whole thing is the greater adoption of telemedicine now makes that short-term consult a little bit more viable, because it makes it a little bit more practically, readily available to do at least that short-term script, because someone can get a little better interaction with the patient and then maybe foster a more full, scale follow-up. But I think that helps mitigate risk, because now we have the technology to step in. Now, I can't tell you how many people were sort of apprehensive about the idea of telemedicine and what it can do, until all of a sudden it became necessitated by the whole pandemic. So things change. Any others? Let's see, I just saw the little thing bump up. It says, I see a lot of chronic pain issues, but don't agree with narcotics. I'm finding the real cause of pain and fixing it. Somebody I absolutely love. There you go. I mean, that's my whole mantra, is we take these patients, we step back, and we look for the underlying cause, try to unravel things in a very patient-centered way. We take into consideration all the other aspects, whether biopsychosocial and things, and put them together and try and figure out what's best for this patient. It just takes time. And the problem is, that's what no one seems to really contribute to some of these patients. And that's what I find most frustrating. So when you see a physician come back and, tell us that's what they're doing, I'm a fan. Tell me where you're practicing, because if I get the ability of referring a patient, I would do that in a heartbeat. Let's see, we got another one. Please let Dr. Clark know that refilling any controlled substance by prescription by another physician in the same practice is illegal, at least in this particular state, Nevada, by state law. So I guess that could be a problem depending on what state you're in.
Thank you, Barry. I'm glad that you're watching. Nice to hear from you.
I was thinking the same thing. I got a text message from him as well, so it was probably the same. And then the person who had the last question said, I'm at the VA in Detroit and a nurse practitioner, so thank you very much. So we appreciate that. That it? I think that might be about it. Well, again, guys, thank you very much for dedicating part of your Saturday afternoon. We really appreciate the opportunity to do that. I know on behalf of Dr. Clark and myself and Dr. Gooden, who seems to be silent at the moment, that we all appreciate anything we can do to help. So, please feel free with questions, comments, concerns. Make sure you fill out that survey for your CE credit. And again, please reference the painweek.org website. Oh, there you go. Any last words?
No, thanks. Great presentation by both you guys. Appreciate listening in. Thank you so much.
Thank you, Dr. Gooden. So have a great day, guys. Enjoy the rest of the weekend. Look forward to seeing you at our next Pain Week premiere session. I think the next one is Wednesday, as a matter of fact, right?
Yes.
So thanks again, guys. Take care.
Okay. Thank you. Enjoy the rest of your weekend, everyone.
Thanks, everyone. Bye-bye.